Good morning, everyone. We'll get started in just a minute. Good morning, everyone. We're going to start the Human Services public hearing for March 5th, and we'll jump right in. So I'm going to invite up Commissioner Gilman from the Department of Administrative Services.
Good morning. Good morning. Thank you so much for having us here. Senator Lesser, Representative Gilchrist, ranking members, Senator Seminara, Representative Case, and distinguished members of the Human Services Committee. My name is Michelle Gilman. I'm the Commissioner of the Department of Administrative Services, and I'm joined by our DAS Assistant Director of Procurement Programs and Services, Antoinette Webster, and she can take any subject matter questions that you may have on this provision as we move forward through today's testimony. You do have testimony submitted to the committee in written form, and I will summarize given the volume of testimony that you have before you today. I do want to thank you for the opportunity to submit testimony in strong support of Senate Bill 312, an act concerning a janitorial work program for persons with a disability and persons with a disadvantage. Again, it's a pleasure for DAS to testify before the Human Services Committee today. This bill, in summary, amends Connecticut General Statutes, Section 4A-82 to clarify the criteria required for certified small or minority businesses to participate in the janitorial work program. This is an ongoing program that DAS oversees, and it was established in 2006 to create and expand work opportunities, full-time jobs, or full-time equivalents at standard wage rates for individuals with disabilities or people with a disadvantage. To be eligible to participate in this program, contractors must employ certain numbers of individuals or be a Connecticut certified small business. And Antoinette can speak further to the provisions and the clarification required if this measure goes forward through the legislative process. This technical adjustment clarifies that these protective requirements are applicable to all companies participating in the janitorial work program, including those around standard wages and other built-in requirements for the program. The Department of Administrative Services did work collaboratively with the Department of Developmental Services, Department of Aging and Disability Services, and the Connecticut Community Nonprofit Alliance on this important proposal. So we thank you for the opportunity again to submit testimony and for your consideration of this impactful bill. Thank you so much.
Great. Thank you so much for being here today and for your testimony. Does anyone have any questions? Senator Lesser.
Yes, thank you, Madam Chair, and good to see you, Commissioner. Thanks for joining us. And it's always good to see DAS in front of Human Services. It doesn't happen enough.
We agree.
So can you just tell us a little bit about the janitorial work program established in 2006, how it works, and the department's involvement with that?
Certainly. I'm going to defer to my colleague, Attorney Antoinette Webster, as she's been intimately involved with the management of this program. Thank you for the question.
Let's see if did I get that right? Turning it on? Great. Good morning, Senator Lesser. In response to your question, the program requires contractors that are going to provide services to the Connecticut Alliance and others to at least fill positions with at least 1/3 of the jobs with persons that have physical or cognitive disabilities. It also requires that those contractors fill at least 1/3 of the jobs under the contract with persons having a disadvantage under the Federal Workforce Innovation and Opportunity Act, or whose income does not exceed 200% of the federal poverty level. It also requires that the contractors pay standard wages to those individuals, and also that the contractors employ at least 200 persons to do this work in the state of Connecticut.
And what is the standard wage?
Oh, I'm not sure the actual number of the standard wage, but it's a required, the wage is required for payment by these contractors
That's
to
great.
those persons.
And if I may, I think it's accurate to state that all of our current contractors are paying standard wage. But because the language currently in the law could be construed as otherwise, this clarification will help alleviate any future concerns or issues around that matter.
We did get one piece, I think, of negative testimony on it. I don't know if you've had a chance to review it. If you haven't, that's okay, but didn't know if you had, and if you had a response. This is from a nonprofit that is, I guess, may or may not be a member, but I know that you've worked with the Alliance, but there was one nonprofit that did testify against.
We are happy to look at that and certainly continue to work with any nonprofits that would be impacted by this. At this time, we don't believe that there's a fiscal impact to any of our current nonprofit partners, but we are happy to work with the Alliance moving forward and work through any continued concerns that there may be.
Yeah, and thank you. And again, the testimony was not from the Alliance is in support of it, but this was from another nonprofit. Thank you very much, and I appreciate your testimony. I think that's all I have at the moment.
Thank you, Senator. Just wanted to ask, how does this proposal, if any, change the preferred purchasing program?
So I'm also going to again defer to Attorney Webster. Antoinette?
It doesn't change that program.
And can you explain a little bit of what that piece is,
Well,
of the program?
What the proposal intends to do is just clarify the requirements for the small businesses and minority businesses to participate in the program. So right now, like I mentioned, there's 4 requirements in the program, which include, I'll just repeat it for the record. The first one is the contractors have to fill positions with 1/3 of those jobs being for people with disability or a person having a disadvantage, as well as certify that they're going to pay the standard wage. There's also the 4th requirement that the businesses, the contractors, have at least 200 people in their employ. So what our language proposes is that all of those things remain consistent, except that small businesses sometimes don't have 200 people in their employ. So for those situations, that 200 number of employees doesn't apply to small businesses. So that's why it's really a benefit for small businesses and minority businesses. And that was really what we wanted clarification so that we can move forward and benefit that group of people as well, group of businesses.
Thank you for that answer.
Sure thing.
Senator Seminara?
Thank you, Madam Chair. And I believe you just clarified my question. So one of my questions earlier in your testimony, I must have misunderstood. I thought you said there needed to be 1/3 of jobs with those with disabilities and 1/3 of those who are considered disadvantaged, but it's 1/3 in total, correct?
No, it's 1/3 plus
And a
another
third.
third.
Oh, so
Correct.
it is a
That's the way-
third plus another third.
Yes, that's the
Okay.
way it's written right now. And we're not touching that.
Okay. All right. Well, thank you very much for
Sure.
clarifying.
Thank you. All right, I don't see any hands on Zoom, so thank you so much for being here today.
Thank you again. Look forward to working with you. Take
Same
care.
here.
Thank you.
Thank you. Yes. And I think they had a minute to breathe. So next is we're going to invite up Commissioner Barton Reeves from the Department of Social Services and her team from DSS.
Good morning. Good morning, Senator Seminara, Representative Gilchrist, Senator Lesser, and other distinguished members of the Human Services Committee. My name is Andrea Barton Reeves, and I'm the Commissioner of the Department of Social Services. I am pleased to appear before you today to offer remarks on several of the bills on today's agenda. The first is House Bill 5053, an act concerning the governor's budget recommendations for health and human services. We're here today to make comment on sections 2 and 7, which implement several provisions included in the governor's budget related to Husky Health. Currently, Connecticut is the only state providing Medicaid coverage to parents and relatives and caregivers over 138% of the federal poverty level. By reducing eligibility for Husky A adults to the same level as that for low-income adults under Husky D, which is 133% plus a 5% income disregard. This bill aligns Connecticut's eligibility with those states that have chosen to expand Medicaid coverage under the Affordable Care Act. But unlike most states, our covered CT program offers eligible individuals who are over income for Medicaid, but have an income at 175% of the federal poverty level, fully subsidized coverage with no monthly premiums and no cost sharing, as well as dental and emergency medical transportation. And moving on to that same section, actually, let me move on to section 7, which speaks to another portion of the governor's bill with respect to Husky C. So the enacted budget added funding with respect to Husky C of $8.5 million in fiscal year 2025, or $15.1 million once we factor in the state share, the Medicaid federal share, to increase income eligibility for Husky C to 105% of the federal poverty level, but that is inclusive of applicable disregards effective October 1, 2024. The funding included in the enacted budget was based on increasing the effective eligibility level from 97% to 105%, including the unearned income disregard. However, the language in the bill, Public Act 23204, would increase that limit to 100 and the income limit to 105% after any authorized income disregards, which actually pushes the rate considerably higher. So in the absence of making this change, the expansion actually would cost $20.9 million in 2025, $38.6 million after factoring the Medicaid share, and would have an annualized cost of $76.5 million, which is actually, as you know, considerably higher than the $8.5 million or the 15.1 after federal share that was anticipated in the governor's budget. With respect to House Bill 5373, an act concerning various revisions to the Human Services Statute, this is the Department of Social Services Technical Revision Bill. And in this bill, we propose to repeal several outdated and obsolete provisions of the Connecticut General Statutes and to make some technical corrections to statutes and require that all administrative appeals be filed in the Superior Court, which is consistent with every other state agency. Section 1 of this Connecticut General Statute, Section 17B 606, actually appoints DSS as the lead agency for persons with physical and mental disabilities. We are not the lead agency, as we know, for people with physical and mental disabilities. In addition to that, the terminology mental disability and physical disability are really no longer used. So we are asking for a repeal of sections A and B. With respect to sections 2 through 4, we recently discovered that there is a Scrivener's error in our statute section 17B 340H1, 17B 340I, and 17B 340D, subsection 11, which actually ends the fiscal quarter on April 30th. And that's not when fiscal quarters end. They end on March 31st. So we're looking for an opportunity to amend the date so that it actually reflects the end of the calendar year. Sections 5 and 6 concerning our rate setting presently provides that an institution, facility, or agency may appeal an adverse decision after an administrative hearing to a 3-person arbitration panel, with 1 arbitrator being appointed from the department. We are the only department in the executive branch that has this process remaining. Rather, such administrative appeals are appropriately referred to Superior Court for adjudication. Specifically, Connecticut General Statute Section 17B61 provides that an applicant aggrieved by a final decision after a fair hearing may appeal their decision to the Superior Court. This amendment would align the process for all entities and individuals seeking an appeal of agency decisions after hearing with that of all other state agencies. With respect to House Bill 6369, an act concerning a benefit cliffs program, we appreciate that the intent of this bill, and we're actively working on ways to creatively address the challenges of benefit cliffs. There is also action that's already in place with the state's 2Gen Council, which includes named proposed participant agencies in the bill, along with other potential state partners. And this group has already commissioned a cost feasibility study from an independent contractor, and those results are due to be available in the next 2 months, at which time DSS and its agency partners would be happy to provide an update and a briefing to the General Assembly. With respect to House Bill 5366, I'm just trying to shorten this because I know you have a very long day. So I'm not going to try to repeat what we've submitted in terms of written testimony. To House Bill 5366, an act concerning covenants not to compete in the nursing home, in the home care industry. Under the current statute, any covenant not to compete related to homemaker, companion, or home health services is deemed against public policy and therefore void and unenforceable. We do believe in the right to workers to choose where they would like to work. And moreover, we do believe in the right of a client's unimpeded ability to contract directly with selected caregivers. Under this proposal, paid training is unidentified in both its intensity and its scope. So potentially, companion homemaker agencies could provide caregivers with abbreviated paid training on a variety of theoretical topics at 6-month intervals, and thereby effectuate multi-year covenants not to compete. This potentiality was clearly not intended when the legislature broadly recognized such covenants not to compete, and therefore we are respectfully opposed to this part of the bill, this bill. With respect to Senate Bill 310, an act concerning compensation for family caregivers and retroactive eligibility, Section 1 does require DSS to set equal payment rates for caregivers authorized to receive compensation from DDS as compared to the rates set for non-professional caregivers. So DSS has enabled people who are participating under the Medicaid state plan Community First Choice and Medicaid home and community-based waivers, such as the Community Home Care Program for Elders, to self-direct their care by choosing and managing their own personal care attendants. And within certain limitations, those PCAs can be family members that the person receives their care from. But in Connecticut, self-directed waivers and self-directed PCAs, they have the right to collective bargaining, which has resulted in a standard statewide schedule of wages and fringes. So outside of these parameters, we do not have the authority to reimburse family members for Medicaid covered services. In section 2, this section proposes to provide up to 3 months of retroactive Medicaid eligibility to individuals applying for home and community-based services. And in short, CMS, the Centers for Medicare and Medicaid Services, does not recognize retroactive eligibility, nor do they recognize any retroactive billing. Coverage is prospective only from the date on which the state Medicaid program approves each person's HCBS program. So private services that clients or families arrange prior to the determination of financial eligibility may be provided by a non-Medicaid provider at any range of rates, but neither of these would be permissible under the HBCS waiver. With respect to Section 3 of the bill, this bill would prohibit individuals from being denied Medicaid on the basis of an asset discovered during the application process, provided that the applicant reports the discovery, takes steps to liquidate the assets, and spends down the assets, sends out the proceeds in accordance with the Medicaid policy. The challenge here is that the exclusion of an otherwise disqualifying asset discovered after the date of application effectively allows institutionalized individuals to possess assets in excess of the Medicaid asset limit and still qualify for assistance. This actually is counter to the manner in which Medicaid works, which does require a spend down. And so therefore we are opposed to this bill. With respect to Senate Bill 318, an act concerning a study of private equity ownership of nursing homes, there are indeed a number of studies actually that are already in place in one of our bills. I think in one of the pieces of testimony we provided to you, we actually have links to studies that have already taken place that do show that where the number of nursing homes, where there's a private equity company that has 50% of a stake or greater, and the ratings of those homes, and what the correlation is between private equity ownership and the ratings in nursing homes. So we can provide those to you. And in essence, we believe that this work may be duplicative of a 2021 working paper that has already been produced by the National Bureau of Economic Research that examined 8,000 nursing home facilities over a 17-year period with a specific focus on private equity ownership. And finally, we'd like to offer comment on Senate Bill 316, an act concerning a study of state-funded assisted living facilities. This would require us to study the costs and the benefits of expanded state-funded assisted living facilities. We respectfully request a revised due date of the study from October 2024 to April 1, 2025 to allow us sufficient time to research this and to provide a comprehensive report. Because in the spirit of full transparency, the same staff that is conducting the rate study and overseeing that would also be the same staff that would be conducting this study. So we'd like the opportunity to work through phase 2 of the rate study and then be able to turn our attention to this study as well. So we are asking for a change in the date in order for us to be able to do both. And that, although I know that there are many bills, that is the extent of the testimony that we are offering in front of you today with respect to these bills. And I am here with many of our subject matter expertise to answer any questions you might have. Thank you.
Great. Thank you so much, Commissioner. So good to see you and the team. I'll jump in with some questions and then I know others have some questions as well, but thank you for your comprehensive testimony. With regards to House Bill 5373, so the Department of Social Services technical bill,
Yes.
just wondering if you could speak to how we've gotten a few testimony in opposition, in particular to the change in the arbitration process as it relates to FQHCs and how they go about trying to get a change in scope for an increased rate. Can you speak to what that process currently looks like and how it would or would not change with what's being proposed?
Yes, yes, I can. And I may call on our subject matter expert also to support me as well as we do. So the way that it works now is that an agency can ask for a change in scope within the statutory timeline that you can do that. And once we receive that change in scope, it is reviewed by our unit, which is within the Department of Health, the Division of Health Services, which is overseen by our Medicaid Director, Guy Woolston. Once that review is complete, then a determination is made as to whether the change in scope, which would then actually translate into a change in the rate, would be approved or disapproved, and a reason why is actually provided to the FQHC. Then they do have a right statutorily to engage in appeal. And that does happen regularly. There is an opportunity during the appeal to provide any other information that, that can be provided to reconsider the decision that had been made. And if we then deny the appeal, actually, the appeal then goes to an arbitration panel, and that panel hears, and then there's a final determination that has been made. So there wouldn't be any change with respect to being able to file for a change in scope. There wouldn't be any change in the opportunity to be able to file for an appeal. None of that would change. What would change then is, instead of going to arbitration, our decision would then be appealable to the Superior Court, which is the way that it is in every other state agency.
Thank you.
Thank you.
My second question, just has to do with, that same process. The judicial branch has testified that they'd like the date to be pushed back to October 24. Would you all be open to that?
We would certainly be open to discussing that with the judicial, but I don't know what their reasons are, which is why I'm hesitating, Representative, but we would be open to having that discussion
Okay.
with them. Yes, of course.
Okay, fantastic. Senator Lesser?
Yes, thank you, Madam Chair. Good to see you, Commissioner, and approximately 2/3 of the Department of Social Services with you this morning.
All right. In our defense, there are 1,900 people that work there, so it's a very small fraction.
You walked in with a impressive entourage, so
They are good to me, and I appreciate that.
I'm not gonna put anybody to shame, but our good friend, the commissioner who was before you, had a much smaller group of folks.
I
with him.
understand.
So you were testifying on a huge number of bills, and so just one quick minor grievance. We got your testimony actually within the last 2 minutes of your testimony.
I
So
see.
there's no possible way for Representative Gilchrist and I to follow
see.
everything. And so in the future, if you could help us get that beforehand, we could read it and then have better questions. when you-
Certainly. I was unaware of that,
Yeah.
so I apologize.
These things happen this time of year, a lot of going on.
Okay.
But just with respect, one to the spouse caregiver bill, which you testified in opposition to, and I was trying to follow your argument is that CMS simply does not allow spouse caregivers to get compensation in the circumstances of the
That's
bill.
correct,
Okay.
under the current rules.
Now, with respect to the Husky, I was trying to follow the math on the Husky C cuts, which, we can argue whether or not it is or isn't a cut. I would argue that it is. So when you said that the cost of the current coverage would be 20.9 million in the current fiscal year, and that is that inclusive of the federal and state share, or is that just the state share?
That is, I want to make sure that I respond to your question correctly. So we're talking Husky C. I'm sorry, would you pose your question again, Senator? I
Yes,
apologize.
so
don't have the testimony in front of
again,
me.
my notes may be inaccurate, but I heard the number, I think I heard $20.9 million as the cost in the current fiscal year if we were to not reduce the eligibility threshold. And that we had 15.5 million budgeted.
Yes.
And but I guess the question there is, I just want to make sure I'm comparing apples to apples, and that are those both inclusive of federal share, or those state share, or what are we talking here?
So no, the 20.9 million is actually 38.6 million after we factor in the federal share.
Okay.
All right.
So, and we have 15.5 million state share, or is that 15.5 million with the federal share?
That's with the federal share. We actually,
Okay.
the enacted budget only anticipated $8.5 million in FY 2025 to increase the eligibility to 105%. But that was inclusive, as I mentioned before, of the applicable disregards. So if you raise it to 105% and then you apply the disregards, the number is exponentially higher than what is currently budgeted.
Okay, so the difference, and if we were to try to keep, I mean, we've certainly had testimony from advocates who are urging us to keep the current threshold.
Certainly.
If we were to do that, though, we would need to come up with, or ask our friends in the Appropriation Committee very nicely to find somewhere on the order of $15 million, if my math is correct, to make that work. Is that?
So you would be talking in an additional in order to get to the 20?
Right,
Okay.
right, my is that, would we need 5 million, or would we need 15 million to keep things at the status quo?
So let
in the
me-
current budget?
Yeah, but actually, Senator, if you don't mind, I feel more comfortable actually getting you those expansion numbers. And so I'm happy to, we could probably get those to you today.
Mhm.
But I mean, if you did the quick math, and if it would be, if it's 15.1 million after factoring in, and you have 38.6 million, then, you know, you're looking at a little over 30, you know, $15 million, I would imagine at this point. But that almost doubles the spending, even including the federal share than what's in the budget. And it actually, with our state share of 8.5 million, it almost, it almost quadruples it. So the number would be pretty exponential.
Now, with respect to the governor's proposed cuts to Husky A, and I understand that it's contemplated that folks will go on to Covered Connecticut. You know, when we
Right.
set up Covered Connecticut, the idea was that it was supposed to provide comparable coverage to the Medicaid program. And for, I think, the majority of people on the program, it does, or it exceeds the coverage. But there's certainly, we've heard some, and I think we've had some conversations about this, trying to understand if that's true in all cases, particularly with regard to folks, you know, there's a small number of individuals on long-term, who are receiving long-term care supports. And
Yes.
so what are, I don't know if you have that information in front of you, but do you just recall some of the things that people might not, services that people might get on Medicaid that they might not on Covered Connecticut if they fall in, you know, hopefully a small group of folks who would get less coverage?
Yes, and are you referring specifically to long-term care or other categories?
Well, first of all, I want to make sure I'm right on long-term care.
Okay,
And then also, but for folks who are not receiving long-term care coverage, there are also some additional categories where Medicaid is in fact more generous. Is that? I mean, I think the biggest two things that we wanted to cover were
Yes.
non-emergency medical and dental, which
That's
are
right.
which are there, but then there are a
That's
few
right.
things that we might have omitted or.
yes, so I'll share with you our analysis of Husky A and Covered CT. When we compare the coverages that are offered under Husky A, and the list is very extensive, and I'm happy to provide a chart that we actually put together that compares the two. And again, I do apologize that you did not receive the testimony in time. There are really three differences. Under Husky A, we do not offer broad coverage for out-of-state providers, and we do not cover infertility services. But under Covered CT, we do offer those coverages, but there is not long-term care support under Covered Connecticut. And I may ask Deputy Commissioner Peter Hadler to come up and offer you more details in that area. The other difference that we can point out under Husky A versus Covered CT is that Husky A does cover medical supplies, and here he is, durable medical equipment and appliances. And it's Covered CT does in fact do the same, but it does it with a fairly narrower benefit. So it does exclude wheelchairs and other kinds of supplies. Those are really the key differences between what's covered under Husky A and Covered CT. Please.
I think Commissioner, you covered it, but if you guys would like to have any more elaboration on that and get a sense of it, I think, you know, we will note that we looked at who's receiving long-term care under the broader Husky A umbrella. And we do anticipate that it's actually a very small number of people who are in this particular income band who would be receiving long-term care savings, estimating about 22 people. You know, we haven't gone and found each individual person, but based on the overall math, that's what we estimate it to be.
Thank you, Deputy Commissioner. I appreciate that the department is here to answer any questions that the commissioner can't, but you seem to be doing just fine. You seem to know all of this stuff. So with respect to the certified community behavioral health bill, I know that this is something that the department has looked at for a while. I know that it's something that our federal partners are also
Yes.
interested in us pursuing.
Yes.
Does the department have any updated, and I apologize, I've been
Right.
trying to find your testimony. And so if you say this all in your testimony, I am deeply sorry, but I don't have it. So
Yes.
do you have any updated response or a sense of where the department is on ability to adopt that?
I don't have an updated response. I can tell you that we are still in dialogue with Senator Murphy's office and with DEMIS and our partners at DCF to explore further the application process and where we might go. And that's the only update I can provide.
And then thank you for that. And then with regard to the private equity ownership study, obviously this is an issue that people have been looking at nationally.
Yes.
you argue that a study is duplicative, which fine. Can we short circuit a study and do something? And if so, what should we consider? I know that Oregon has looked
Yeah.
at legislation. I don't think it's necessary for us to look at to study something for the sake of studying it. But if there are,
Yes.
if there's some policies considerations that, we should discuss as a committee or as a legislature, I think that would be helpful.
Yes, I can certainly explore that for you. We're very fortunate that we live in a state that has a number of excellent colleges and universities. There might be some resources that we might be able to leverage and that might be able to help us provide some expertise in a shorter period of time.
Two more questions. I promise I won't go all day. But with respect to the language in, I think it was the tech bill that Representative Gilchrist mentioned earlier, for change, with a change of scope for community health centers. My sense was, though, that one of the big takeaways from the phase 1 of the Medicaid rate study was, the need to sort of beef up existing rate review processes within DSS. Do you see that as running counter to what we're trying to do there in terms of, we have a existing process. It may not work great, but it is the process we have for amending FQHC rates. Is that something that we're moving backwards on, or how do you sort of see that fitting in with the Medicaid rate study?
So I'm hoping I'm understanding your question. So second, the FQHCs are going to be in the next study of the next part of the rate study.
Right.
So I don't see us moving backwards at all. And the opportunity to study those rates more carefully, we're actually very much looking forward to that. And we don't really see a contradiction between that and moving to the appeals process that every other state agency is using. We understand the concerns that the FQHCs have raised, and we've had opportunity to discuss that. But we are still committed to doing that study and to have them included in phase 2. And then, as we had done in phase 1, when we came to you and reported to you, your joint committee on phase 1, we did report that there was a significant disparity in the rates with respect to behavioral health. And so therefore, we have an opportunity to look at that more objectively and make some recommendations, which we're working on now, that we can bring back to you as to adjustments that we believe should be made. And we believe the same thing can happen with phase 2 of the rate study. After we have an opportunity to have that depth of analysis completed, we find that we are finding that is a very, very useful tool in making reasoned and planful decisions about the way in which rates should be adjusted.
And I appreciate it. And I guess part of the question is that, we can make one-time adjustments based
Yeah.
on the best analysis that your research and,
Yes.
collaboratively based on budget realities and our ability to pay. But one of the big recommendations, and sort of beyond any specific area that I got out of the rate study, was that really it shouldn't be the members of the legislature figuring out whether or not we want to pay a particular area covered by Medicaid more, that we need some sort of rational basis
That's
to
right.
assess rates on an ongoing basis. And so
That's
that's why I see something like the change of scope function in DSS currently is an important place, because that there you have an existing mechanism to adjust FQHC rates. And so, yes, I understand I
Yes.
don't want to get ahead of the FQHC portion of the study, but
Right.
if there's a way to beef up that existing process, it seems like that would be a place to start, or at least to not go backwards on it.
Yes.
With
appreciate that.
with respect to, and my last question, with respect to the state-funded assisted living facility bill, this is where I will plead abject ignorance, but I assume the reason the proponent was pushing for a state-funded assisted living pilot is because, are we precluded from using Medicaid funds for assisted living? Is that something that CMS does not allow us to do? Or are there places where we can, in fact, use?
Yeah, I don't know the answer to that question. Where's the?
Heidi,
I don't know the answer to that question, so thank you, DC Hadler. Okay, and here comes the state Medicaid
You just
director.
say your name for the record.
you got to put the
put on
microphone on.
Yeah.
Rookie mistake. Guy Wolf, Medicaid Director here at DSS. Yes to your question, Senator.
We are precluded from using, okay.
And in the study, just to reiterate what the commissioner was saying, we the same group of people that are focusing on phase 2 of the rate study. And we just would need a little bit more time to do that.
Thank you, Senator. Representative Cook, followed by Representative Ferraro.
Thank you, Madam Chairman. Commissioner, it's nice to see you and your team.
Good morning.
There's no rookie mistakes here. I want to, and I'm sure that you know exactly which bill that I want to talk about, and that would be the nursing home long care staff, or the nursing home bill and a review of study. I agree with you that we don't need to continue to study something that we already know. My question kind of goes a little bit more where the senator was starting about, is there something else that we need to look for? But I think the concern that we have is I'm looking at where we are. And I pull up one nursing home in my town out of a few, and it has a star rating of 1.
Right.
We know that it is in bad shape, and that's one of 2 that's in really bad shape. They're owned by the same people. And I think that the problem that we have is we recognize that the primary ownerships have legs with LLCs and a variety of different owners, and they're able to hide money and then look like they're broke, but they're really not. And part of the concern that this specific group of nursing homes that I have in my town are also now that their owners are not paying their healthcare insurance, which means now the staff are not able to go to the doctor because nobody will see them because their insurance is no longer valid. So if we're looking at minimal, and 1 star is, well, for my world, that's below minimal. When we're talking about caring for folks, we know that they're in dire straits, but yet they still have figured out a way to manipulate the system to get reimbursement from us. Whether or not they own the building, they own the pharmacies, they pay rent to themselves, you fill in all the blanks. And tracking those dollars. So if we don't study it anymore, which I'm fine, I could pull the trigger on a whole lot of different decisions when it comes to this conversation. What do we do next? Because right now we have people dying. We have people being abused. We have people being overdosed. We have 1 CNA for 80 residents in some cases. This is deplorable for me. And there is no time that's acceptable for repair. So if we don't do a study, which again, I agree with you, it's duplicative, what do we do now?
Thank you for the question, Representative. Do you think we're okay? Yeah, I think we're good. Thank you. Yes, so thank you, Representative. So let me just clarify. I'm not suggesting that we don't gather the information that a study may conclude, right, may gather as a result of that. What we're suggesting here is that perhaps we don't have to do the study, but to the senator's point, perhaps there is a way for us to gather the information in existing studies and then bring that back. And so that probably, senators, is more responsive to the question that you were asking. And there are, obviously, there's the Department of Public Health and there's the Office of Healthcare Strategy that I would really like to pull in as partners in doing that. And as I mentioned, we are very fortunate to live in a state that has a number of exceptional colleges and universities that I think we can also leverage to help bring that information forward. So I'm not suggesting that we not gather the information. I'm suggesting that the vehicle through which it is suggested we do that in this particular bill, which is to conduct another study, might not necessarily be what we do, because I completely agree with you. We hear those stories all the time, and I know that the governor, has expressed significant concern with respect to the quality of nursing homes, which is why in DSS, you will see that we are actually working, we are now in our 2nd year of our acuity-based payments for nursing homes. There's no secret that there are homes that are closing, right? They're turning in their keys and saying, I'm not, providing services anymore. And my colleague, Commissioner Jatani, you may have heard her testifying in aging, that the number of complaints that are received from nursing homes, while she's addressing them and the backlog, that more are coming in every day because it is an industry that needs oversight and support. So I completely agree with you. I will work with my colleagues in other state agencies, and as I said, perhaps leverage the expertise in colleges and universities to bring something back to the committee that may not necessarily be this study, but it will be a comprehensive gathering of information, particularly around private equity and nursing homes, and perhaps have a discussion about what the next step should be.
I appreciate that. I have
Okay.
my intern, that was her first task,
Mm,
was to follow funding, and the file is continuing to grow, and then trying to literally follow all the tentacles that the, you know, the head of the company and then all of its little LLCs and then all the other private equity ownerships really affect.
yes.
With all of that being said, and I don't want, and I know that you know this, but I would be remiss to not say this. If we have organizations like the Ombudsman's Office that's charged to investigate those allegations, and I know that this is not a part of the bill, but if they're charged to do that, but they're understaffed, you know, getting around our very small state, if you only have 6 people or 7 people working in a department, is nearly impossible with the flood of concerns. So as you're looking at the funding piece, I'm looking at the care piece, and I'm by no means insinuating that you are not.
That's correct.
But I'm saying that yesterday was too late for some of these folks, and tomorrow might be too late for others. So as we are focusing on dollars and cents, which I respect, because as we know, some of our nursing homes, and there was just a great article done a week or so ago about the millions upon millions of dollars of back taxes that are owned by certain nursing home owners to our state, let alone to our municipalities. That's criminal for me. And it's criminal that our staff are not getting the health care. It's criminal that our elderly and the people that are in those facilities are not getting the care that they deserve. And I also find it criminal, although this is not your decision, that we do not inflate the budget of the Ombudsman's Office to actually do what they're charged to do. So people can go to bed every night in what they consider to be their home, whether it be permanent or temporary, feeling safe. So I thank your office for being dedicated to the cause. I would just like to push fast forward on ensuring that some of these folks are held accountable. So
Yes.
thank you.
Thank you.
Thank you.
Great. Thank you, Representative. Representative Farrar, who's on Zoom.
Thank you, Madam Chair. First off, I'd like to thank the Commissioner for the great work and the great report, and she always does a great job in connecting all the dots with regards to some of these numbers and line items. I'm also like to commend Representative Cook for bringing up the other half of the equation, which, you know, we can talk about dollars and cents, as she said, but the quality of care is equally as important. And we need to fund both sides of the equation. So I do appreciate Representative Cook and her comments and her question. My question is very simple, and it's just really to provide some reference for me. You spoke earlier of the 105% of the poverty rate and raising it from 97.5 to 105. Could you just elaborate as to why you felt the need to raise that marker was important?
Thank you for your question. This was actually an initiative to create greater capacity for income eligibility under Husky C. So this allows us to have more people covered under Husky C by raising the income eligibility from 97 to 105. But the challenge here is that there isn't enough funding to raise it in the ways in which the statute currently reads, which means that we would be over budget by a considerable amount of money, approximately, if you consider the expansion, which is 20.9 million, which is and then 38.6 million after you factor in the state federal share. So really here the issue is around the way in which you read the statute and interpret it so that you can raise it from 97 to 105, including the unearned income disregard. And I can ask Deputy Commissioner Hadler to come back and speak some more as to what exactly unearned income disregard is. But there are categories of income that people may have that we, under the Medicaid and so under the Husky rules, we can actually count as if it actually doesn't count against their income, so that they can still meet the 105% of federal poverty level standard. And that is actually a good thing, because we want more people to be covered and have health insurance, because we're a better state when everyone is healthier and has access to good quality health care. The challenge here is that if we raise it to 105% after the authorized income disregards, the cost to do that is exponentially higher than what is in the budget.
I appreciate that, and just follow up on that. What is the actual income? 105% above the federal poverty rate. What
So
is that actual figure?
And here comes DC Hadler. I will have Deputy Commissioner Hadler answer that because I'm looking for my chart because there are lots and lots, but go ahead. Yes.
Yeah, I can't pretend to have the entire thing memorized off the top of my head, but I can tell you that 100% of FPL for a household of one is $1,255 a month for this upcoming calendar year. So that should give you a sense. If you could take 5% of that, if I can do the math very quickly, it's probably about another $50. Oh, look at this, old charts. So that is the that is the ballpark for where we are when we talk about 105% of federal poverty level. The corresponding 100% is 1,255 for a household of one, which is the most common scenario for a Husky C household.
Thank you. I appreciate that. And just knowing that for reference, I would agree with the commissioner that increasing the threshold by such a small amount to include the additional people to be eligible for coverage is still in a position where folks that actually need the coverage and don't have it in that income range can be helped immensely in this situation. I guess then the question is, the last question I would have, she talked about, the commissioner spoke about immeasurable increases to the budget. Is there any possible range of increase to the budget that I could focus on? I mean, how much money are we talking about through you?
Thank you for your question. As we stand or sit here today, there are no additional resources beyond what has already been enacted in the governor's budget, which is the $8.5 million for us to raise Husky C. If we stick to those parameters that's already been budgeted, and we then read the language to have that include the unearned income disregard, we can in fact implement this as I had described. If we read it differently, that's what raises the amount. So I just want to be clear that this is not an all or nothing proposition. If we interpret the statute in a way that allows us to spend the 8.5 million or the 15.1 million after factoring the Medicaid share, we can in fact increase the income eligibility. It's the manner in which we apply the language that has to do with the unearned income disregard. That's the only really challenge here in this respect with respect to this bill.
Okay, I thank you. And I thank the commissioner. I thank the chairs for indulging me the time.
Thank you, Representative Ferraro. I have a few more questions. Just want to bring attention to House Bill 5372. I don't think you spoke about it unless I missed it, but it is in the testimony. So this is Medicaid funding for beds reserved for chronic disease hospital patients temporarily transferred to acute care hospitals. Long title. It's my understanding that the intent of this legislation is so when someone who is in an acute care hospital might need to go to the emergency room or the hospital for just a few days. What's currently happening is because Medicaid pays for the bed itself, they lose that spot. And then they are going to have to go back to that acute care hospital. And so in order to account for that, the proposal would give 15 days. Is that this? I was told that that is what we currently do with nursing homes, and that Medicaid holds that we allow for Medicaid to pay for a bed for 15 days. Do you know if that's the case? Do we currently do that?
Yeah, I'm going to ask Nicole Godborn to join me, but I thought I saw Nicole. Did she leave? Oh, there she is. Okay. Yes, I'm going to ask Nicole to join me as our subject matter expert here. So conceptually, yes, and Nicole will speak to it. The challenge is that Medicaid will pay for a patient to be in one place without some exceptions, right? So we would have to amend our state plan, but I'll let Nicole speak to the rest of it.
Good morning. I'm Nicole Godburn, Director of Reimbursement and Certificate of Need for the department. Yes, correct. Currently in residential settings such as nursing homes, residential care homes, RCHs, ICF facilities, there are bed hold policies for if a resident wishes to leave and, for example, go on vacation with their family or go for an extended visit for a period of time with friends or family. There's also bed hold policies for those settings for someone who does go to the hospital for a period of time to hold the bed for their return back to the facility. So we do have current policy around that where the bed is paid for while that person is away.
Great, thank you. So my then follow-up is, beyond the potential cost of doing this, are there other barriers or things that we would need to change in order to have that done? You just referenced offhand kind of it won't pay for two things at the same time. Is that a
That's-
potential problem?
That is potentially, so unless we have a bed hold policy,
Okay.
as Nicole described, that's generally the rule with Medicaid. They will pay for a person to be in one place at a time. They will not normally pay for a person to hold a place. And I'm speaking from my experience at Hartford, where people would leave who knew, right? Now I'm at DSS, but at that point, we were looking to DSS to help pay for, right, the room and board rates at our group homes. So at that point, if a person left for vacation, or often as they were growing older, they would move, they would actually probably be in rehab or the hospital and then rehab over time. We would feel the financial pinch of that because we were not reimbursed while that person was away. So at the time, that commissioner did explore a bed hold policy. I haven't been there quite some time, so I'm not sure if we have one now or not. So that's really the policy. So I also think about it in the context of when we would have an individual who would be, let's say, at a hospital. This is somewhat analogous, but not quite. And then we would ask our staff to be with that person because they were the person with whom they were most familiar and the family would feel comfortable. And Medicaid would not necessarily pay for that because they either received care in their residential setting or in the hospital, and they believed they were already paying for care in the hospital. And that was the hospital staff and Medicaid that would cover that. So there are pretty strict rules around the ways that works. And we can certainly explore it further, but as it stands right now, we don't have a bed hold policy for chronic care with that people that move into an acute care setting. Anything else I should add, Nicole? Okay.
Great, thank you. That's
Thank
very,
you.
very
All
helpful.
right.
You're still on.
No,
Representative
I'm not going
David.
anywhere. Thanks, Nicole.
Thank you, Commissioner. I really appreciate your testimony. I'm still kind of working through it, so we may have follow-up questions for
Certainly.
you. I'm going to talk about Husky C, my favorite topic.
Yes.
Can you highlight for folks what the income difference is by this change in policy on a per person basis? So what is, if we change this policy to undo what was done in the Public Act last year, what does that mean for a disabled individual in terms of monthly income that they would be able to have?
I don't have that number right now. I can certainly provide that. I don't know if anybody from my team has that number. And here comes Deputy Commissioner Hadler again. Now you see, Representative, why I asked everyone to come. Okay.
Thank you, Commissioner, and thank you, Representative Dathan. I think the number that you might be looking for is the unearned income disregard, which is the most common disregard,
right.
and that would be $511 in this upcoming calendar year. So
Okay.
that's the differential.
So
But
that's the monthly amount, $511. So an individual would be able to not qualify with that $500. Now, if we look at that 97%, what is the individual monthly income of that if we were to look at it for the before the income disregards?
So 97%, again, using the reference point of 1,255 as the 100% of FPL would be 3% lower than that. So low 1,200s thereabouts.
So we're saying that a disabled, handicapped person would have about a third less income in order to be able to qualify for Husky C under this new proposal. So you're saying that if we were to look at the original proposal as passed in statute, we're looking at close to $1,800 a month that a person can earn in order to qualify for this benefit. With the actual amount of $1,276. That's a huge amount of income. That's like 30-something% less income. I don't know many apartments in the state that you can get a 1-bedroom apartment for $1,276. That's not even including food. And I'm concerned that our disabled population are asked to make $511 less a month in order to qualify for a benefit that if they were able-bodied, they would be able to qualify for. And some of the things that are covered under Medicare for these folks, they're not able to get those under the Husky C. I have a lot of concerns with this. I've talked about it a lot, and it's a significant portion. You know, we're asking our disabled population to be on the brink of poverty for them to be able to get basic health care that they're not getting under Medicare.
If I just can, I don't,
Please,
I
please.
understand exactly what you're saying, and I
Exactly.
appreciate it very much. I think, you're right, there's a big dollar difference, all right? And it really comes down to the calculation, but I think the challenge means, if it is increased by that much, we're talking about annualized costs of $76 million a year. And that's what it comes down to. It's really, it's a financial question at this point, and that's the type of, dollar level on the out years that wasn't budgeted through the proposal last year. So I think it's very important that everybody understands that, the differences between, yes, of course, higher eligibility means more access to a program, but it comes with costs. And I think that's the main point. I understand completely what you're saying. I just want to also highlight that there are a few variations. It's not always unearned income. Sometimes, if you have earned income, there's a different type of disregard. So it's never totally the same for everyone. But in general, that's the idea, right? It would be about $1,800 before you'd have to do a spend down. You can also spend down some of that income and qualify for this coverage, right? So you can spend it down and you can get 6 months of coverage at a time under that process. But it is really a matter of dollars when it comes down to it.
Yeah, I understand. I mean, Husky C, I do have last year's version. I don't know if we have the new version yet for the Husky program income guidelines, and I'm looking forward to seeing that because I carry it around with me. I know that Husky C is about 40% of our costs for the Medicaid program. Is that still accurate for 2024?
Yes, that's about the right number.
Okay. And it's about 9.4% of our members based on the current income levels. Is that right?
Yes, that's right. I'm going to double check because I do have that chart with me, but yes, that's about right.
Okay. Can you walk us through the asset requirements for Husky C and if those would be affected by this? Because I understand from my research that not only are our income levels low for our region, but our asset amounts are low.
Yeah, I mean, I could briefly give you the gist of it, which is that for regular Husky C, it's $1,600 asset limit for an individual and $2,400 for a couple. That is slightly lower than the national average. It's probably, 2,000 and 3,000 is the most common scenario around the country. But it's not, obviously wildly out of line with what the norm is nationally for that population, for that program. There's also MedConnect too, which also falls under the Husky C umbrella. That's Medicaid for the working disabled, and that has higher asset limits of $10,000 and $15,000. So it's a little bit of a different approach for those who are, have higher earned income and are working. So
less than a cost of a car.
Having been car shopping recently, way less than the car. Some cars.
Okay. So you understand where I'm going. We live in a state that is more expensive than the national average. And the fact that we're asking our disabled elderly population to not be able to have assets to live and be able to work if they're able to work and thrive. It's a major concern for me, and I'm just going to voice my concern to my good chairman that I'd like to carry on these conversations. Thank you. Thank you, Madam Chair. Thank you, Commissioner.
Thank you.
Thank you, Deputy Commissioner.
Great. Thank you, Representative. I don't see any other hands. So thank you all for being here today. Thank you, Commissioner. We'll
Thank
see you
you.
again soon, I'm
All
sure.
right, that's fine. Thank you.
Wonderful. We have reached the hour mark, so we're going to go to the public and then back to officials. So I'd like to call up Lori Sims.
Good afternoon, Chair Gilchrist and members of the Human Services Committee. My name is Lori Sims, and I'm a Director of Government Relations for CareForth. On behalf of CareForth, we express our sincere appreciation for the committee for raising Senate Bill 311, an act concerning the Connecticut Home Care Program for the elderly. This comprehensive legislation addresses critical challenges hindering timely access to services for those in need of long-term care. The bill reflects thoughtful consideration, and we applaud the committee's commitment to advancing policies for care at home by family caregivers. While endorsing Senate Bill 311 in its entirety, my testimony emphasizes two provisions: enabling spouses to serve as paid caregivers and introducing presumptive eligibility for home care community-based services. CareForth has been a provider of adult family living in Connecticut since 2014, and we currently serve, and the program pretty much started at the end of 2013. And we currently serve 450 Connecticut Home Care Program for the elderly. That's the waiver we're under, participants and their family caregivers. We provide adult family living exclusively with the goal of enabling individuals to receive quality care at home, thereby avoiding high cost and more restrictive institutional care. This unique approach involves the family caregiver assisting the member with daily personal care needs, while the caregiver receives ongoing education, coaching, emotional support, and a modest financial stipend from an AFL provider organization such as CareForth. We deploy professional care teams, nurses, social workers, and other disciplines who are skilled in working with informal caregivers, and our simple technology-enabled communication platform, it's an app, facilitates regular connections between the caregivers and the coaches. By expanding participation to spouses, we will be able to provide support and education to the people who typically need it most, which in many cases is taking care of a spouse, taking care of a family member with chronic debilitating disease such as Alzheimer's. We do not believe there will be additional costs to the state of Connecticut in this section. This policy will either be budget neutral or result in savings to DSS if a participant chooses a spouse as a caregiver over another home care service. It's a substitute if that's what the family would like. As for the section in the bill regarding presumptive eligibility, current states that fast track eligibility for HCBS, according to the AARP's 2023 scorecard report, found that if applicants are assessed and presumptively found to be eligible, they are rarely determined to be ineligible once their full applications are processed. In summary, while fully supporting Senate Bill 311, CareForth urges thoughtful considerations of these provisions as they bear the potential to significantly shape the evolution of Connecticut's HCBS delivery system. Thank you.
Thank you, Ms. Sims. Any questions? All right, seeing none, thank you for your testimony and your time. Is Senator Martin with us? Not in the room, right? Or Senator Kelly? All right, then we're going to go online to, is number 13 with us? Nope, don't see number 13. They already went first. And number 14, I don't see. Are they on? Okay, so we're going to Andrea Swenson.
Good afternoon, Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, and the members of the Human Services Committee. Thank you for the opportunity to offer testimony on behalf of Catholic Charities Archdiocese of Hartford in support of SB number 315, an act implementing the Certified Community Behavioral Health Model in the Medicaid program. My name is Andrea Swenson, and I'm the Senior Director of Behavioral Health at Catholic Charities. Catholic Charities is a family and children's human service agency which employs approximately 400 human service delivery professionals and provides services to over 10,000 individuals and families annually without regard to race, religion, or economic circumstances. As a multi-service agency, we serve adults and children with significant mental illness, substance use disorders, physical and intellectual disabilities, and victims of domestic or community violence. We currently operate 4 behavioral health clinics in Hartford, Torrington, Waterbury, and New Haven. In 2021, we received a 2-year grant from SAMHSA to open our first CCBHC at our Institute for the Hispanic Family in Hartford. Becoming a CCBHC has helped us to transform our behavioral health and substance use services for both children and adults. The addition of peer recovery specialists, targeted case managers, and community health workers paired with evidence-based clinical treatment has not only improved the quality of our services, but client outcomes as well. In addition, becoming a CCBHC allowed us to bring a primary care provider on site so we could provide integrated care regardless of an individual's ability to pay for services. We have also formed a number of new partnerships with other agencies such as the Veterans Administration, and we are now serving more veterans in our clinic as a result. While this initial grant ended in 2023, we were successful in getting another grant for a Hartford clinic to advance the work of the CCBHC, and a second grant to establish a new CCBHC in our New Haven clinic. This grant has been instrumental in providing enhanced services for clients, and approving this bill would allow for these services to continue long after the grant has ended. Our experience with implementing a CCBHC in Hartford in 2021 and now beginning a second one in New Haven has reinforced our belief that Connecticut should become a CCBHC state. The CCBHC funding has enabled us to better meet the increasing behavioral health and substance use needs in the community in a more comprehensive and timely way. If approved, this model would benefit all clients in Connecticut and would help to address the growing need for these services across the state. Lastly, the funding mechanism for CCBHCs, a prospective payment system that incentivizes providers to serve those most in need, would give CCBHCs and their partners the opportunity to better plan for and balance their budgets while increasing access to care. Across states with existing CCBHC systems, the total number of people receiving care increased nearly 10%, and this would help address the increasing need for behavioral health and substance use services in Connecticut. Thank you for the opportunity to testify in support of SB 315.
Thank you, Ms. Swenson, for your testimony and for being here today. I don't see any questions. So we'll move on. Is number 16 with us? I don't think so. Mr. Luna? Nope. Then moving to number 17 is Marie Allen here. All right. How about number 18, Thomas Burr? Yay. Come on up.
All right, good afternoon, Representative Gilchrist, Senator Lesser, members of the Human Services Committee. My name is Thomas Burr. I'm the Public Policy Manager for the Connecticut chapter of the National Alliance on Mental Illness, otherwise known as NAMI Connecticut. I'm here regarding HB 5053, an act concerning the governor's budget recommendations for health and human services. You've already been a lot of discussion about the income and asset limits around Husky C, and you certainly, or the other flavors of Husky, and you certainly have my written testimony. So just really quickly, I just want to say that as an organization, we are all about access to healthcare. We find that the people that we care about do better when there are no impediments to getting the healthcare that they need. And we feel that the changes that were implemented in the governor's proposed budget are going to actually harm the people that we care about. And it's really just as simple as that. So we would urge you not to implement these changes, but to go ahead with the spirit of what was already in statute, and continue these chipping away at these arbitrarily just extremely low income and asset levels that you've touched upon earlier in your back and forth with the commissioner and the staff at DSS. Thank you.
Thank you, Mr. Burr. Senator Lesser?
Hi, it's good to see you, Tom. Thank you for your testimony. And just trying to understand the concern, because there are differences between, you're talking about specific, but the cuts to Husky A and the shift onto Covered Connecticut. Is that you, that just,
All of
what are you talking about? All the
All of it, you know, just all the different flavors that we touched on earlier.
But can I ask you about that?
You can.
Okay, so
I'll be honest with you though, Senator.
Yeah.
I do not have my staff here. Like the DSS commissioner, my go-to
your
person.
40-person entourage is waiting outside.
Exactly.
Okay.
The person that I lean on to get into the weeds on this will be testifying later today, and that's the representative of Disability Rights Connecticut, Sheldon Tubman.
Okay.
So you can ask
Yeah, we
me. I'm
met
not
too.
sure I can
Okay.
answer.
All right. So I will ask a question, which is, we just got the phase 1 of the Medicaid rate study back, which finds that Connecticut is abysmal at rates for behavioral health care in a Medicaid program.
And we hear that all the time. Yeah.
So, and I also think that there are a lot of great providers out there who nevertheless see Medicaid patients, which is wonderful.
And thank
But,
God for that.
Thank
yes.
God for that. But Covered Connecticut pays commercial rates to providers who receive behavioral health clients. So if, for the very narrow purpose of seeing, if I'm trying to see a therapist because I have a behavioral health condition, how do I do that? I would think you'd be better off. If you have two similarly situated people, you'd be better off on Covered Connecticut than on Medicaid. I understand that there are lots of other folks, and that doesn't necessarily, that may not meet everybody's need, but for that specific purpose, wouldn't you want people to go on a system that is based on commercial rates?
Well, if we can't fix the Medicaid rates, then you make a compelling argument. Honestly, I think we should be looking at fixing the Medicaid rates. I know that when you compare some private insurance, the Medicaid provider world can often provide services that you can never get in private healthcare insurance. So the Medicaid system, at least from what they can provide people that we care about with mental health conditions, is a really wonderful system. And again, my understanding, and again, I hesitate to get too far in the weeds on this because I know I'll screw it up, but my understanding, there are some limitations as to what Covered Connecticut can provide that may or may not be something that you can get in Medicaid. And I'm, again, would defer the specifics on that to people who come after me who know this stuff a lot better than I do.
Well, I have a hunch now that Sheldon may speak to that, but we'll hear from him when he gets here. But that's why I wanted to sort of dive into the details. And I understand you don't like the governor's proposal, but we're not here to defend him. But just in terms of looking at it and understanding what the proposals are, that's why I asked.
Understood.
And
Thank you,
Madam Chair. I thank you for the time. I'll yield back to you.
Great. Seeing no other hands. Thank you so much for your testimony today.
Thank you.
Next, we'll hear from Rick Sebastian. Just please push the button. Sorry about that. And when the microphone will turn red. There you go.
Shall I restart? I will restart. Good afternoon, Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. My name is Rick Sebastian. I'm the parent of an adult daughter with multiple disabilities, and I'm here representing the Kennedy Collective. Kennedy Collective is a 73-year-old 501c3 nonprofit operating and headquartered in Trumbull. I'm here today to oppose Senate Bill 312, the janitorial program that we heard Commissioner from DAS speak about earlier today. Reasons for my opposition are numerous. I realize that this is a reauthorization with some technical language clarification on the bill. The bill was created initially in 2012, 2013 timeframe, several years before I arrived in the state of Connecticut. And there are some intended and unintended consequences related with the entire operation of the Qualified Partnership Program, as well as the Preferred Purchasing Program. The Preferred Purchasing Program has been legislatively authorized for more than 40 years, QP since about 2012, 2013 timeframe. In that 2012, 2013 timeframe, when QP was established, there was a rule that was put into place that prohibited nonprofits only, not any other janitorial contract in the state, from charging the state for our increased cost of janitorial supplies. Since that particular time period, our cost of supplies we're a janitorial contractor. We employ 70 people in a 3-tiered line of business. We're a federal contractor. We hold 14 state contracts, and we have 3 commercial contracts. And we see janitorial services as a growing line of business in one of our 5 social enterprises that we operate. The janitorial supply prohibition increase is draconian. There's no other business that any state, the state of Connecticut or any state in the country, prohibits its contractor from charging increased supplies. And we haven't been able to do so. Our supplies have increased 300% in that time frame. In the last 6 years since my arrival at the state of Connecticut, we've had $20,000 worth of leakage in our janitorial supplies. What do I mean by leakage? Theft by Connecticut state employees of our janitorial supplies. We've had to eat all of those costs. Senate Bill 312, if enacted and if DAS is allowed to continue on its path of creating qualified partnerships, will result in the termination of 300 people with disabilities. There are currently 450 people operating on preferred purchasing contracts throughout the state for almost all state agencies. Those 450 people, there is a ratio of employment in the PPP program. We heard from the commissioner earlier that 33% employment for people with disabilities is part of Senate Bill 312, part of the Qualified Partnership Program. 33% of 450, 150 people would continue to possibly be employed, 300 people would be unemployed. So I'm here to oppose that and to raise awareness that there are problems with both PPP and the Qualified Partnership Program. And nowhere is there any worse problem than in the nonprofit sector. How does the state of Connecticut, when we have 110,000 approximate vacancies, unfilled jobs, how do we create the opportunity to eliminate 500 jobs from people with disabilities and the people that support them in a janitorial line of business only? Thank you very much for your attention.
Thank you so much, Mr. Sebastian. Few questions. So this is a newer topic for me. And so if you could go back to the preferred purchasing. So you were saying that that's been around for over 40 years here
Yes,
in the
ma'am.
state. Okay. And under the DAS proposal, or is there currently, as the program currently stands, is there a difference between how nonprofits and small businesses are treated?
Yes. So under QP, nonprofits, so we operate as a social enterprise. A social enterprise is a triple bottom line business, the mission of creating employment for disadvantaged people. Our population, our primary population are people with disabilities. Second bottom line is environmental impact. Our janitorial social enterprise is a custodial industry management standard green building certified company. That's akin to ISO certification from the manufacturing sector. So we have an international certification. We're not allowed to bid under QP on any janitorial contract throughout the state of Connecticut. The only prohibited business entity in the state is the nonprofit sector. The QP is specific about that in identifying the nonprofit as only a community rehabilitation program. We're both. We're a hybrid. We know that we are under the impression that you as legislators are aware that we have nonprofits in the state that are traditional human services providers. We're funded by DDS, BRS, and DMIS to provide supports to people. We also self-fund, self-generate revenue in our 5 social enterprises. We're if 312 is allowed to go forward and DAS continues their practice of creating QPs, the nonprofit social enterprise, the nonprofit janitorial contractor goes away. So what we're saying with this bill and this law that's been enacted now for 11 years is that the nonprofit sector is restricted from any competition.
Thank you. That's helpful. Representative Leeper.
Thanks, Madam Chair. I just want to thank Rick for coming and bringing this really important issue to our attention, and also for all the work he does through Kennedy Collective. Kennedy Collective is a phenomenal organization that is bringing members of the disability community into our lives through all of these social enterprises and helping people find fulfillment and meaning in all the ways they should. And we certainly need to foster that work and make it easier for you to provide jobs for these individuals and not make it more difficult. So I'm really grateful for your advocacy and looking forward to how we can work together. And if you have specific suggestions on how we can ensure that groups like yours are not being left out of placing these individuals in these types of jobs, I'd love to hear it.
Yeah, thank you very much for that, Representative Leeper. I want to focus on the word that you just said about placement. So the QP program creates the opportunity for the nonprofit to be a placement agency that essentially eliminates $500,000 of top line revenue. Our 14 contracts generate $500,000 in revenue. We're using net income from those contracts to subsidize underfunded human services pieces of the operation. So we could be a placement agency, but that means that we eliminate our entire janitorial social enterprise, which doesn't seem right to me. It actually seems counter to what we're trying to do with the creation of employment. Our entire mode of operation is creating both placement activity, providing those supports, those on-the-job accommodations, but also creating the employment as the employer of record. All of that employment opportunity goes away for us. 35 people with disabilities, 16 without disabilities who may have economic disadvantage, and maybe supervisors are working on those 14 contracts. If we just take that 33% ratio, we're losing a third of that workforce on top of the workforce that we already employ throughout our entire line of businesses. Thank you.
Great. Thank you. Thank you for being here. I'm sure we will be following up with some
Thank you very
additional
much.
questions. Have a great day. We have been joined by Senator Kelly, so I'm going to invite him up and then we'll go back to the public. Hello, Senator.
Hello, and thank you for the opportunity to be with you this morning. To Chairman Lesser and Gilchrist, ranking members Seminara, Case, and the distinguished members of the Human Service Committee, thank you. Expanding access to the Connecticut Home Care Program for the elderly must be our common goal. We have taken positive steps forward by raising asset levels for individuals and married couples. Another positive step has been the reduction of copays. But we can and must do more to allow more state residents to access home care. Doing so will make our state better for our elderly residents, their families, and caregivers. Our state has a high cost of living, and as we seek to make Connecticut more affordable for middle-class families, a key part of that effort must focus on our seniors. Passing policies which provide seniors with fiscal relief and improve their quality of life while allowing them to age in place with dignity will help Connecticut to become a role model for the nation. Given the choice, an overwhelming number of seniors choose to live in their own home as long as they can. And when I say overwhelming, it's overwhelming. Passing policies which allow more seniors to stay in their homes also helps keep more seniors out of nursing homes. These policy choices help to generate significant long-term savings for the state of Connecticut and improved health outcomes. Budgets are about priorities, and I know that members of this panel would agree that our seniors and their health care must be among our top priorities as public policy makers. For these reasons, we must further increase access to the Connecticut Home Care Program for elders by establishing presumptive eligibility for Medicaid-funded services, reduce co-payments, increase asset limits, expand categories for persons who may be covered under state-funded program, and authorize compensation for family caregivers. Senate Bill 311 is a vehicle for sending a positive message to seniors throughout our state that we value them and that we want them to stay right here in the great state of Connecticut. Thank you.
Thank you, Senator. Thank you for being here today
Sure.
and for your advocacy.
Absolutely. Thank you for the opportunity and to make the accommodation. I certainly appreciate that. And also, this is a very difficult committee. So I do commend you for all your efforts in working through what I see, and I know you see, to be very, very difficult but important issues. So thank you.
Thank you, Senator.
I don't have a whole lot else to add other than to thank you for coming here and with your thoughtful suggestions, and appreciate your depth of knowledge and expertise on this area. So thank you.
Certainly, if I can ever be a resource, don't hesitate to ask. Thank you.
Thank you. Next, we'll hear from Diane Lauricella. She is with us on Zoom.
I guess good day or good afternoon. Senator Lesser, Representative Gilchrist, the ranking members, and the esteemed committee members of the Human Services Committee of the Legislature. You have a lot of important and complicated work, and the two bills that my name is Diane Lauricella. I live in Norwalk, and through experiences that occurred in past with my mother and current experience I'm having with being a companion to an elderly family friend, I wanted to offer some quick suggestions. But I will say what I was going to put forth was so well said by your previous speaker. I think it was Senator Kelly. So I absolutely lift up and support everything he just said to you. Senate Bill 310, the one main key thing I wanted to emphasize, and this is where my current situation is, that there is a New York State, I think it's called the Freedom Fund, and I would like this committee to have the staff or you yourselves explore New York State's Freedom Fund, which allows the senior or the person needing the caregiving to appoint the person that gets compensated. And the reason I'm mentioning this is currently I am not a blood relative of the person that I am helping part-time taking care of on a part-time basis. I'm not related to them, so that my compensation, if this is passed eventually, there is no pathway for me other than marrying the person, and that's not possible, or that's not desired. I do think you should open up the language to define family appointed caregivers. So it's not just blood relatives and spouses, although I'm glad you're adding the spousal point. I also think in 310, you should look at beyond Medicaid, because many seniors are asset rich, yet the caregivers they know or they respect or they trust should not have to go into poverty in order to keep an eye on them and assist them on occasion when they need it. On Senate Bill 311, in the home care program, I absolutely think it needs to be expanded. I am actually in the queue for the Aging Committee hearing today, and I'll be speaking about expanding that program and supporting our current ombudsman so that we know when there are issues, they can be followed up on and resolved quickly. The reason I'm mentioning this is in line 67, where you talk about compensation and training. I want to make sure that you again look at the New York State Freedom Fund. Aging in place with dignity is important, but that you make whatever training that is devised, it has to be user-friendly, preferably videos that are easy and online and can be viewed whenever that person has the time that they could spare. I lastly wanted to thank one of your members, Lucy Dathan. She, after several years of asking other members from my area, she took me seriously, and I am forever thanking her for. After we had a discussion about the situation with my mother in Newtown many years ago, in 2017 through 2018, she took my concern seriously and she formed a study committee. And from that study committee, she and all of you have rightfully expanded the ombudsman program and other things concerning home health care for seniors. So I very much thank you, Representative Dathan, for being a good listener. And also, even though it's taking longer than we want, things are moving in a more positive direction, a more equitable direction for our seniors, and helping those that are the caregivers. And we are exhausted and we do need some compensation. So thank you very much.
Thank you so much for your testimony, Representative Dathan.
Thank you very much, Diane, for your testimony today. It's really appreciated. Just wanted to also say thank you for the advocacy that you've done over the years for all of the folks that are aging in place. And you have really highlighted the need for these ombudsman programs. And I appreciate your patience as we slowly build this up. I do want you to focus in and look at 5001 and see all the great things that the speaker has prioritized in this session to support the elderly. I also very much appreciate your comments regarding Senate Bill 310 and 311. You know, I'm sure you heard DSS and their testimony saying that these are actually pretty expensive because we cannot do under the CMS rules. So this would be fully state funded. It is something I think we need to continue to look at and see if we can expand those programs as more of our seniors have chosen to age in place rather than go into a care facility. So thank you for your work, and I don't have any specific questions. Thank you, Madam Chair.
Representative Dathan, may I just follow up, please?
Sure.
I did listen to DSS's discussion about the cost, which is always the bottom line. I actually think because of what is being proposed in 5001 and even 5296 in the Aging Committee and today's Senate Bill 310 and 311, I think, and I'm a former regulator in the environmental field, I think some of these programs and expansions can be funded with enforcement fines that are well placed and fairly done. But without enforcement, there's no way to collect fines, even if it's with some of the agencies in place that do home hospice care, which was the thing that brought me to the table in the first place. A question about a large home hospice care company. I will not name them, but the thing is, there is a need for enforcement and using those fines to turn around and expand and improve the program and provide support where needed. Thank you.
Thank you for that idea. I'm sure that's something that we will look at as a committee. So appreciate your testimony. Thank you, Madam Chair.
Thank you, Representative. And thank you again for your testimony today.
Thank you.
We're going to go to Senator Martin, who has joined us. Hello, Senator.
Good morning. Thank you for addressing SB 316, which is a study of using state dollars to allow a person to stay in an assisted living facility rather than being placed in a skilled nursing facility. I've, Madam Chair, and I know Senator Lesser was here earlier, but I've developed a piece of property years ago. It started out as a senior congregate housing, and because of the need, it turned into an assisted care facility. But I'm here today because of a constituent of mine who is dealing with a relative who lives in a current assisted care facility, but is using all her funds, but in a very short amount of time, those funds are going to be depleted, and she'll be on Title 19 and then moving over to a skilled care facility. I'm going to let John Ring, who is my constituent in Bristol, our kids grew up together, and he came up with this thought, and I thought, gee, would save the state a considerable amount of money if we did decide to pursue this idea. So, John?
Hello, committee.
Hello, welcome.
I'm going to read a statement that I prepared. Dear members of the Human Services Committee, my name is John Ring. I'm a concerned citizen of Bristol and the nephew who has power of attorney, and I'm the healthcare agent for my elderly aunt. I'm here to give my support for the study of state-funded assisted living services. I'm here today because my aunt, who lives in an assisted living facility, will shortly run out of funds to maintain her residence there and be forced to enter a skilled nursing facility, even though she does not need that level of care. My aunt came to this country 61 years ago and became a U.S. citizen. She worked at a low-wage factory job until the age of 85. My aunt was a hard worker and saver and did not spend her money foolishly. She will turn 92 on March 24th of this year. In August of 2022, my aunt was no longer able to and could not afford services that would allow her to stay at home alone. In September of 22, she moved it to Farmington Station Assisted Living in Farmington. My aunt has mild dementia, and the move from her private residence to assisted living was very traumatic for her. My aunt's savings will probably last her another year to year and a half, depending on future rate increases. After that, she will be evicted and inappropriately placed into a nursing home, even though she may not need 24-hour medical care and supervision that a skilled nursing facility provides. This would devastate her mentally and probably place her into a deep depression. Currently, the monthly cost for her assisted living is $4,751, which includes a studio apartment, meals, activities, housekeeping services, and medication management. This comes out to a yearly cost of $57,012. I looked up the Connecticut Department of Social Services July 1st of 23 case mix report, rate report, and nursing home reimbursement rates currently range from $227 a day to $408 a day. The average is $296 a day for nursing homes in Connecticut. This comes out to an average yearly cost per patient of $108,128. The total savings to the state for my aunt, if she were allowed to stay in assisted living and be reimbursed through Medicaid, would probably save the state approximately $51,000 a year. So we don't know how many people are currently in a skilled nursing facility that probably still belong in assisted living. We're just under 60,000 people in nursing homes in Connecticut. Say 1,000 people don't belong there and could be placed into a skilled nursing facility. 1,000 times 50,000 savings per year is $50 million per year. And that's just assuming 1,000 of those 60,000 don't belong there. Expanded out over 10 years, you're talking about $500 million. And I also looked at the Genworth Cost of Care Survey. It's a nationally recognized company that surveys costs. And they said that the projected average cost of in-home homemaker services is $65,500. This is nationwide. Connecticut's probably higher. Home health aid services average out to $67,500. Now, this is in addition to the patient or the client that's receiving these services, they still have to pay for rent, food, household expenditures out of their own pocket. So by comparison, the median assisted living cost is $59,000. So if that person were to move into assisted living, they would be paying $59,000 on average, which would include all of their expenditures, versus staying at home, which is costing $65,000 to $67,000 in addition to out-of-pocket costs for living. It's almost like a no-brainer that we would take Medicaid funds and use them to assist these people. It would be a savings to the state. So I'd like to thank the committee for hearing my testimony today. And your consideration is greatly appreciated by myself, by my aunt, and others that are in the same predicament. And I'd like to also let you know that I do have experience with nursing homes. My wife does. She did home health care. She did hospice care. She was an RN in a nursing home. And she was also an administrator of a nursing home. One thing she says to me is, never let me go into a nursing home. Don't ever do that. Assisted living is great compared to a nursing home. My wife and I took care of my dad, who had Alzheimer's, for 5 years. We took care of him in home, along with 4 young children. So I do have experience and knowledge of what it takes and what the effect is on the elderly. Thank you very much.
Thank you very much. Thank you for bringing this idea to us. And I think a study would really help us to better figure this out. So.
Yeah, yes, I think, when I first heard it from John, I thought that was brilliant, that, we could save that type of money just by simply allowing Medicaid payments to be made to assisted living facilities where currently, apparently they're not. This is what we're looking for government to do, is to try to find efficiencies within our structure. And this, I thought, was, gee, what a great way to save the state a lot of money, and as well as a better place for them to live, rather than being moved from where they currently are and not wanting to move, but being forced to move. Okay.
Great. Thank you. Thank you both for being here.
Thank you, everyone.
Representative Johnson.
I want to thank you so much for that, testimony and bringing this idea to us. I just wondered, we do have rest homes, and how does that fit in with the personal care attendants taking care of people in these assisted living facilities? Have you looked at the levels of care in terms of the certification of those different types of places? Now, rest home is not a skilled nursing facility or a / nursing home, but it is a place where people can be independent. They have their meals provided to them. They do have Medicaid payments, which are much less than a skilled nursing facility / nursing home. And I just wondered if you had looked at that in terms of this situation, and to try and maybe even, it would be great to be able to take the personal care attendant buildings and make them into / rest homes in certain areas. I wondered if you've given that any thought.
We did look at the homes, but the homes didn't provide nursing care. She needs help with taking her medicines and being reminded and cued. And these homes wouldn't provide that. Plus, they provide 24-hour-a-day security. The assisted living does.
I'm sorry, I meant rest homes, not rest homes. Is a different lower certification. It's
Right,
does
but-
not have doesn't have regular nursing care. It does provide for people's meals, and a home care nurse can come into the rest home, but not, can't make sure that they're updated with their medication more than once a day, say, for example.
Right. In her case, she requires twice a day medication. So having somebody come into the home twice a day at, say, $60 a visit, $120 a day just to dispense medication. Times 30 days, that's $3,500 just to have somebody come into a home to give her medication. Whereas here she's able to socialize with the people in there. The facility holds 80 people. So she's got many people that she can socialize with. Group homes are very small usually. They're probably 10 to 12 people.
No, it's not a group home, it's a rest home.
Oh,
That's-
rest home, I'm sorry. Rest home. Okay,
There's so
rest-
many different homes we
Yeah.
have. It's nice that, I guess we do need a study.
Yeah.
For making the point for us.
Yeah. we
But
did-
yeah, so it's a much different situation and
Mhm.
you might even have, I mean, even if you're in your own home, the Medicare program might pay for a nurse to come in twice a day to provide the medication. But again, having the socialization is much better for mental health. It's much better to have people in a group. And once they're established, if they have some type of memory loss, then it's really much better for their memory to be maintained by interacting with people. So those are the kinds of things that I'm looking for. So thank you so much for this.
Thank you, Sandra.
Thank you both so much.
Thank you, committee, Madam Chair. Thank
Have
you.
a great afternoon. Next, we're going to go to number 17, Marie Allen, who has joined us on Zoom.
Good afternoon, Representative Gilchrist, Senator Lesser, Ranking Member Senator Nara, Representative Case. Thank you for your time and efforts in support of older adults. My name is Marie Allen. I'm the director of the Southwestern Connecticut Agency on Aging. And we participate as the care management agency for the Connecticut Home Care Program, serving about 3,500 older adults and persons with disabilities to give them an alternative to nursing home placement. Wanted to start with SB 310 and just say that allowing family caregivers to support older loved ones in an effort to supplement the shrinking workforce, which is a true difficulty and barrier to care for many older adults, is something that the area agencies on aging support. We are doing this today with the Adult Family Living Program through the Connecticut Home Care Program, albeit the program does not allow legally liable relatives, a spouse, or a parent of a minor child to participate as it's currently written. Applying for Medicaid is extremely complex. Unintentional omissions of an asset should not result in penalties other than requiring the individual to spend down the asset until the eligibility can be resumed. The paperwork involved in applying for Medicaid is incredibly difficult to navigate. We have attorneys who call our office regularly to try and get clarification on some of the Medicaid eligibility rules. And we feel that sometimes someone will have an asset that they just simply omitted. They forgot they even had it. It's a stock that they may have had buried somewhere, and it is found when DSS does the eligibility determination. So we are hoping that that would not create a penalty for them. Now moving on to Senate Bill 311, the Aging CT supports Senate Bill 11. Individuals discharged from hospital or facing care crisis in the community may apply for admission to a nursing home facility or for the Medicaid waiver. Older adults who would qualify for Medicaid can receive their services in the home through the Connecticut Home Care Program, or they can go into a nursing facility. If they go into a nursing facility, the process of determining eligibility for Medicaid begins on admission, and they work with the nursing home social workers and others to put together their application. In the home, it falls on the family, the loved one, and the client themselves to pull together the Medicaid application. This is not easy. It's a 5-year look back. You have to produce financial records about any accounts that you had, any expenditures over $1,000. You have to look at things like life insurance, the face value of it, burial contracts, divorce decrees. You have to gather your birth certificate. This can be extremely trying for someone in need of immediate care. As it stands, most applications take upwards of 60 to 90 days to be qualified for the Connecticut Home Care Program. Presumptive eligibility, as it's presented in—
Ellen, your time has expired. Can you please summarize?
Certainly. Presumptive eligibility would give us a chance to assume the person is eligible, get the care in the community, and prevent a premature institutional admission. Thank you.
Great. Thank you so much. Representative Hughes.
Hey, thank you, Madam Chair, and thank you, Marie. Good to see you. We do
Same here.
have right now in aging downstairs, the presumptive eligibility for home care expansion, the expansion for family adult living to include spouse. That bill is being heard right now downstairs. And especially retroactive presumptive eligibility for family caregivers for Medicaid treatment. There's another bill also in aging right now. So so these dovetail very nicely. What I wanted to ask you about, and also for the record, almost 90%, more than 90% of those presumptive eligibility applications that are reviewed and we say, okay, we think you're presumptively eligible for Medicaid are granted. And there's like a 1% that aren't, especially after people give the correct paperwork and address the outstanding missing, verification and all that kind of stuff. So it's a good bet for the state to take that risk on. And it can really save folks going directly into institutional care when they could be better served at home. I did want to ask you, do you have any experience with expanding PACE now in Connecticut that we passed last year?
Yes, there has not been a request for proposals for PACE. So the PACE program has not actually started, although legislators have given us a pathway to begin it. I know there are a number of PACE organizations who have come into Connecticut. They are learning the landscape, reaching out to area agencies on aging, as well as other significant providers of care for older adults, and trying to best understand who they can partner with. What PACE will do is it will really support a percentage of clients who are already in the Connecticut Home Care Program, because Medicaid is a requirement of the PACE program. And it will provide additional supports, really holistic, wrapping the person around with all kinds of supports, including general practitioner, nursing services, bathing services, all in one single location. And then the individual would leave after spending the day in a PACE facility, back to their home and enjoy additional services if needed in the overnight. So conceptually, it makes a lot of sense, and I certainly hope that Connecticut will have that RFP and we will be able to have another tool in our toolbox to support older adults.
Thank you, Marie. It just kind of gives us an illustration of how we need to strengthen, expand that ecosystem of supports and funding, quite frankly, and reimbursement for older adults or all kinds of folks, but especially older adults, because we're attacking it bit by bit, but all of these are important to get up and running, especially as we deal with the workforce shortage in the care industry. So to consolidate some of these services would be awesome. Thank you.
Thank you.
Thank you, Representative. Thank you, Marie. Have a great
Thank you.
afternoon.
You too.
Next is Sabrina Trochi.
Good afternoon. I thank each and every one of you for the opportunity to provide comments today regarding House Bill 5373. My name is Sabrina Trokey. I'm the President CEO of Wheeler Health. Wheeler is a federally qualified health center with health centers in Hartford, New Britain, Bristol, Plainville, and Waterbury. We provide comprehensive integrated primary care, mental health, substance abuse recovery services to over 21,000 children and adults in some of our most vulnerable, medically underserved communities. Approximately 80% of our patients are on Husky. Wheeler opposes Section 5 of House Bill 5373, which is designed to make it harder, even more harder than what it is today. And I think I would be best using the word impossible for health centers and other providers to obtain reasonable rates. As you're aware, federal law dictates that health centers are paid based on prospective payment system. This is a cost-based process that is protected by federal regulations. Each federally qualified health center in Connecticut has a Medicaid rate for medical visits, dental visits, and one for behavioral health. Federal law dictates that each state utilize a process called a change in scope to submit to their state Medicaid agency for increased rates. This is tied to any time that there's a change in service type, duration, or intensity. Despite the clarity in the federal law, Connecticut has a long-standing history of denying legitimate requests for such rate adjustments and manufacturing arbitrary reasons to deny health center requests. This attempt to remove arbitration feels like another attempt to prevent health centers from seeking the rate adjustments that are required under both state and federal law. Arbitration is when health centers finally get a fair opportunity to present to our case to a neutral party. Wheeler became a health center in 2014. We became a health center after being a behavioral health center for 50 plus years because of what we were seeing with our adult behavioral health population, over 65 to 75% presenting with no primary care and unaddressed chronic medical conditions. When we became a health center in 2014, the rate we were given for each of those service types was based on 1999 cost reports, and they were established in 2001. Today, in 2024, I still have rates that are based on 1999 cost reports. Wheeler submitted our formal request to DSS in March 31st of 2023. To increase our rates. This was documented based on having now 17 health center sites across Connecticut and serving 21,000 plus patients. Our rate was denied on a categorical reason. 6 to 8 other health centers were also denied in 2023. The cost for us to go through the administrative hearing process has been enormous. The commissioner in her testimony, Commissioner Barton Reeves stated that in reference to arbitration, this results in an unnecessary expenditure of state resources. The process Connecticut is currently putting health centers through is resulting in unnecessary use of our dollars, which could be invested in providing more care and more services. I urge you to reject that proposal and not pass it forward. Thank you.
Thank you, Ms. Trocchi. Thank you for being, am I saying that correct?
It's Trokey, but
Trokey.
yes.
Thank you for being here today, and do want to say next week we'll hear the Medicaid rates bill. Many of us are horrified that the rates are so woefully low. So the Department of Social Services testified, obviously this is their revision bill, and they support this change. Can you talk me through a little more of what does the current appeals process cost you? Since it seems like based on what you've described and the other FQHCs have described, you have to go that's where it ends up because the scope, you don't end up getting the increase. So what does that currently cost you and what do you anticipate the change would cost or look like?
So the current process, we submitted March 31st, my request of 2023. I did not hear back from the Department of Social Services until October 18th, 2023 of the categorical denial. On October 25th of 2023, immediately provided my request for the administrative rehearing, which is the next process. I, to date, have not received an official date for that. The department has tried multiple times to stall the rehearing, scheduling that administrative date, most recently stating, let's wait until the end of the legislative session. Each one of those requires legal intervention and legal cost associated with that. We would still have to go through this process and then would have to go to Superior Court. And that would be a much more lengthier, much more costly process. And it doesn't make sense when there are a number of laws, both at the state and federal law level, that that dictate how the rate increase process should be enacted, and it's just not happening.
Thank you. Thank you so much for that answer, and very helpful. I'm just looking to see. I don't see any other hands. Thank you.
Right. Thank you.
Have a great afternoon. Is Mark Griffin with us? Okay. Kathy Flaherty.
Great.
Good afternoon, Representative Gilchrist and members of the Human Services Committee. My name is Kathy Flaherty. I'm the Executive Director of Connecticut Legal Rights Project, and we're a statewide nonprofit that provides legal services to DMIS clients. I'm here to testify in opposition to Section 2 and 7 of HB 5053 because we're really concerned about the cuts the governor has proposed to both Husky C and Husky A. I definitely appreciated the questions that several legislators asked of the commissioner earlier this morning. And I think it is accurate to discuss what the governor is proposing to do to Husky C as a cut. Very intentionally, this legislature passed a bill that said it's 105% after disregards are taken in place. And you know, the legislative intent of that should be followed. And if that means going to appropriations to ask for extra money to ensure that legislative intent is followed, we believe that that's what you should do. Because we are part of the Stop Husky Health Discrimination Coalition, which advocated for that. The programs for older adults and people with disabilities, those Husky programs have the lowest income and lowest asset limits of any Husky programs. And I believe it was Representative Dathan who really talked about what is the impact we are having on both older adults and people with disabilities in the state, where we're forcing them to stay barely above the federal poverty line, a line that does not reflect the cost of living in the state to have access to health care. Concerned about the Husky A and switching people over to Covered Connecticut, because there is a segment of caregivers, and it may be only 22 people, but it's people. And they were, the department talked about, you know, how expanding access to health insurance does come with a cost, and it does, but the not expanding it also comes with a much more significant cost to human lives. So I would encourage this committee to reject those portions of the bill. Thank you.
Great. Thank you, Ms. Flaherty. I don't see any hands. Thank you for your testimony today. Next is Sean Frick with us.
Great.
Good afternoon, members of the Human Services Committee. My name is Sean Frick. I'm the CEO of the Community Health Center Association of Connecticut. We are the statewide trade association that represents community health centers, also known as FQHCs. I'm here today in opposition to Section 5 of House Bill 5373. I've also submitted written testimony. You've already heard from Sabrina Trokey, CEO of Wheeler Clinic, and later you'll hear from other health center leaders who strongly oppose this section of the bill as well. The proposal relates to the process by which health centers and other healthcare providers seek Medicaid rate changes through DSS. For community health centers, the process is called change in scope. And I want to take a moment to note that in the department's testimony, they call the current process a fair process. I would disagree with that. I would say perhaps the only part of the process that is fair is the binding arbitration, which they are proposing to take away. There's a separate legislation that we hope we would like to talk about on a different day, potentially solve that issue. But what the department is attempting to do with this legislation is to take a broken process and remove any possibility that health centers can receive a rate increase. For context, in 2023, 7 of our member health centers applied for a rate change, but none have completed the process. Today, the process goes like this. A health center applies for a change in scope based on a change in service, duration, or intensity. DSS almost always denies the initial rate change request, often for arbitrary reasons. At this point, a health center can either continue with the request. Step 2 is the health center can appeal the decision for a second review by DSS, which is most typically denied. At this point, you go to the third step of the process, where a health center can continue with its request by going to either binding arbitration or by suing and going to Superior Court. The new proposal from DSS seeks to eliminate the cleaner, quicker, and less expensive binding arbitration option for health centers and force them to go through a lengthy and expensive process in court or give up the rate request. So this leads us to ask, why is DSS focusing on limiting the rights of FQHCs instead of trying to address the broken change in scope process, which is creating these appeals? Unfortunately, it seems the purpose of this proposal is to remove any hope FQHCs may have from being successful in seeking rate increases or even attempting them by making the process more expensive. In fact, if you examine the agency's legislative proposal to the governor, DSS references a recent binding arbitration they participated in with Fairhaven Community Healthcare. DSS actually claims that eliminating binding arbitration will save the state money. Why? Because they know health centers can't afford to go to court. Notably, and it doesn't seem as a coincidence, the Attorney General's office recently issued an RFP for $500,000 for outside counsel attorneys to work on Medicaid and other federal issues for the Department of Social Services. In other words, it appears that DSS isn't willing to create a transparent process to address known rate issues, but DSS is willing to spend scarce state resources to fight against rate increases in the most expensive way possible for health centers. We ask you to reject this legislation. We are happy to discuss this proposal with you further. Thank you.
Great. Thank you, Sean. And thank you for outlining in your testimony the current steps. That's going to be very helpful for us.
Thank you.
I don't see any hands. Have a great afternoon.
Thank you.
Is Emily Morrison with us? Right. Go right ahead.
Hello, good afternoon, members of the Human Services Committee. My name is Emily Morrison. I am a Putnam resident and Director of Development and Prevention Services Division Director at United Services Incorporated. United Services is a nonprofit certified community behavioral health clinic, CCBHC, serving 21 towns in northeastern Connecticut. We operate more than 30 programs under our one administration, including outpatient mental health for adults, children, and families, substance use treatment, including medication-assisted treatment for alcohol, opioid, and tobacco use disorders, primary care, crisis services, family services and parenting programs, wraparound supportive services for individuals with serious mental illness, domestic violence programs, and prevention programs. Thank you for the opportunity to testify in support of SB 315, an act implementing the Certified Community Behavioral Health Model in the Medicaid program. CCBHCs are a proven model of care that provide comprehensive behavioral health services across the lifespan, with an emphasis on evidence-based practices and care coordination. United Services was awarded a CCBHC Planning, Development, and Implementation grant from the Federal Substance Abuse and Mental Health Services Administration in September 2022. We achieved certification as a CCBHC in September 2023 after a year of adding care coordination staff, updating workflows and policies, and finally submitting an attestation detailing how we met every criteria in the more than 100 pages of federal CCBHC standards. It was a long road, but one absolutely worth traveling for our agency, our clients, and our communities. Care coordination has been the biggest benefit. It has allowed us to catch people who are previously falling through the cracks. Some of our biggest success stories center around people with complex medical issues who hadn't been able to navigate the health system on their own. This left them in a constant cycle of going in and out of the emergency department. With care coordination, they were able to obtain appointments with specialists, which our staff then attended with them to help them advocate for themselves and better understand their care. We already have quite the collection of these stories in just a short amount of time that we've been a CCBHC, as well as ones for individuals who were emerging from homelessness or from prison. Our staff were able to help them navigate re-entry, apply for benefits and insurance, and receive needed medical and behavioral health care. Care coordination was not something that was previously available to everyone at our agency because it was only funded for people who met a very specific criteria. Our CCBHC funding has removed this barrier and added this critical component of care for everyone who walks through our doors. Federal data has shown that CCBHCs improve access to behavioral health care and lower healthcare costs across the system. We can see it already. Fewer hospitalizations means lower healthcare costs. The CCBHC model is beneficial not only for the patients receiving care, but for the healthcare system and the state as a whole. Lastly, the funding mechanism for CCBHC's prospective payment system would give CCBHCs the opportunity to better plan for and balance their budgets while increasing access to care. Other states have reported increases in access to care because the prospective payment system allowed CCBHCs to hire more staff. With the prospective payment system, United Services could hire more staff and increase access to care. Thank you for the opportunity to testify in support of SB 315.
Perfectly timed testimony. Thank you so much for being here and for sharing your experience. It's really helpful. I don't see any hands. Thank you again. Have a great afternoon. Is number 27, Courtney Sheehan with us? Yay. Come right up.
Hello. Good afternoon, Madam Chair and members of the committee. My name is Courtney Sheehan. I'm a Senior Program Director and CCBHC Project Director at Community Health Resources, CHR. CHR provides mental health and substance use treatment, supported housing, and foster care, serving 25,000 children, families, and adults throughout Connecticut. In 2018, after meeting rigorous eligibility requirements, we were awarded our first of 4 CCBHC grants, and we're the first in Connecticut meeting the CCBHC certification criteria set forth by SAMHSA. We currently operate 2 certified community behavioral health clinics, one in Central Connecticut and one in Northeast Connecticut. Thank you for the opportunity to testify today in support of SB 315, an act implementing the certified community behavioral health model in the Medicaid program. The CCBHC model is vitally important to Connecticut because it provides critical resources not currently funded by our state behavioral health care system. For example, CCBHC resources currently support 24/7 crisis services, on-site primary care access, recovery and engagement services, in-school counseling services for youth, community outreaches after an emergency room visit or hospitalization, caregiver supports, same-day access to life-saving medications to treat opiate use, rapid access to medications to manage chronic conditions like schizophrenia, and the list goes on. The good news is we, like other CCBHCs across the nation, know CCBHCs as a proven model of care to provide comprehensive behavioral health services and substance use treatments, including crisis care, regardless of an individual's ability to pay for those services. And as a CCBHC since 2018, we have seen the CCBHC model directly benefiting the people of Connecticut, both people seeking services and the family and friends who love them. The CCBHC model has already provided critical care to many in Connecticut. To consider losing those resources when the federal grants end is a staggering consideration. High quality, accessible, and effective behavioral healthcare services are essential components of a complete healthcare system. I recommend the CCBHC model as a best practice pathway to achieve that for Connecticut. The CCBHC model is beneficial not only for the patients receiving care, but for the state as a whole. Thank you for the opportunity to testify in support of SB 315.
Thank you, Ms. Sheehan. Again, this is very eye-opening and helpful to know how many entities in the state are already certified. So thank you for being here. Have a great afternoon. Next, we'll go to number 28, Richard Famaglietti. Sorry about that.
Good afternoon, Human Services Committee, and that's quite all right. My name's pretty tough to pronounce. I'm here today to testify in opposition to the sections of House Bill 5053, which cuts Husky programs. Last year, the Husky Sea Coalition advocated to end the discrimination to elderly and people with disabilities regarding the income and asset limits for Medicaid Husky Sea eligibility. I should correct myself, it was just for the income limits. These two groups are subjected to much lower income and asset limits for accessing Medicaid as able-bodied, non-disabled people do. Last session, our legislators approved the increase to Husky Sea income limit, which our governor signed into law. The increase was way overdue, allowing an income for a single person. I don't know the exact number, but it was very close to around $1,800 a month. Even with that much income, imagine a one-bedroom apartment in a crappy drug-filled neighborhood is roughly $1,500 a month, and you got to still try to make ends meet with $1,800 a month. That's pretty difficult. Our governor in this bill is now proposing new language to again give the shaft to our elderly and people with disabilities by reinstating the discrimination by again lowering the income limit for Husky Sea. I'm asking our legislators who passed this into law last year not to give in to the governor and to protect the law as written last session, which I believe was 105% of the poverty level after certain income and disregards. Our elderly paid their taxes while they were working and young. Our working disabled, like me, still pay taxes, but have lower income asset limits to access the same programs as able-bodied people. Why is this? Guardrails, we heard these. They should be protecting people, not to prevent access to vital programs like Husky Sea. The governor needs a slap upside his head. Please, legislators, do not let the governor ruin this. Let this Husky Sea income asset limit get passed. In regards to the asset limit, there shouldn't be any. I'm on MedConnect for the employee disabled. When I stop working, I have to dump my assets in order to be eligible for Husky Sea because I'm still going to need those services when I stop working. Get rid of the asset limit altogether. All it does is give money to the attorneys who have to write trusts for people who can afford trust for the workaround. Thank you.
Thank you so much for your testimony and for your continued advocacy.
You're welcome.
All right, next we will go to Jennifer Granger.
Thank you. My name is Jennifer Granger. I am the president and CEO of United Community and Family Services, UCFS Healthcare for short, and I'm here to testify in opposition to House Bill 5373. In operation since 1877, UCFS Healthcare is a nonprofit organization serving the most vulnerable residents throughout 900 square miles of Eastern Connecticut. We serve 16,500 people through our federally qualified health centers, FQHCs, of which 60% or 9,900 are enrolled in the Medicaid program. As a critical federally qualified health center provider in the Medicaid system, we oppose Section 5 of House Bill 5373, which is designed to make it harder for health centers to obtain fair rates. Per federal law, FQHCs are paid based on the prospective payment system basis. Federal law dictates that each state creates a process to enable FQHCs to submit to their state Medicaid agency for rate increases in any qualified service tied to a change in the service type, duration, or intensity. Despite the clarity of federal law, Connecticut's DSS has a long history of denying legitimate requests for these rate adjustments. No one disputes Connecticut's right to create a process for FQHCs and their rate adjustments based on the federal law. However, it does not have the authority to sweepingly reject requests based on an arbitrary process. In 2023, UCFS Healthcare twice applied and has twice been denied rate increases for changes in scope of service that we provided our community health center. While federal law does not compel the state to set time limits on the submission of such qualifying requests, DSS does. In fact, they require notification within 30 days of any change, and if notification is not received in 30 days, the health center is informed that they have permanently foregone all future applications for rate adjustments related to that change. For example, UCFS did not notify DSS within 30 days of our implementation of a new multi-million-dollar electronic health record that went live on March 3rd, 2020, 10 days before the declaration of the COVID-19 public health emergency. Therefore, DSS concluded our qualification for a rate increase ended 30 days later on April 2nd, 2020, regardless of the ongoing burden of cost. Arbitration is currently an option to have this decision reversed should our appeal not be granted. In 2022, DSS's process was challenged through the very arbitration procedure it seeks to eliminate. An arbitration panel found in favor of the petitioning health center, Fairhaven, and reversed DSS's decision and remanded the case back to DSS to reopen the rehearing process. It bears notice that DSS seeks to eliminate the arbitration panel option after 23 years of a prospective payment systems implementation and specifically cites the Fairhaven case as a motivating factor. As UCFS has 2 cases pending rehearing with DSS on our rejected applications, I would like the option of an arbitration panel to review my cases. The resources needed to bring a case to Superior Court compared to an arbitration panel are prohibitive to FQHCs. Unfortunately, it seems like that is the purpose of this proposal, to prevent health centers from receiving the rate increases that they should by federal law receive. I strongly urge you to reject this proposal and thank you so much for your consideration. And please feel free to reach out with any questions, and my testimony has been uploaded to the system. Thank you.
Thank you so much, Ms. Granger. Very helpful. All right. Is Michael Taylor with us? Oh, all right. You're in person. Come on up.
Good afternoon, Representative Gilchrist and all members of the Human Services Committee. I want to thank you for allowing public comments regarding the proceedings, and I want to be very clear that, like my colleagues, I am in strong opposition to House Bill 5373, Section 5, and I'll provide a bit of context. I am the CEO of the Cornell Scott Hill Health Center in New Haven. The Cornell Scott Hill Health Center last year celebrated 55 years of service to New Haven residents. At present, we serve almost 56,000 Connecticut residents, 34,000 of which are Husky recipients. So obviously, we have a long history of serving state residents, and particularly those who are underserved. The process being proposed by DSS is really problematic and very costly for health centers. I'll give you a very good example in the instance of the Cornell Scott Hill Health Center. We are one of those health centers that was denied a requested rate increase. And here's the result of that denial today. Every day, for every Husky recipient that we serve and provide medical services, we lose $55. Every day, for every Husky recipient that we provide dental services, we lose $95. That is financially unsustainable. So, putting in place a measure that's proposed under 5373 to limit option for a rate reconsideration to taking it to Superior Court would make a rate appeal for us absolutely prohibitive. I urge you to oppose this bill.
Thank you so much, Mr. Taylor, for being here today and for your testimony. Have a great afternoon. Next, we will hear, sorry, let me get my Zoom up, from Rick Markello.
Thank you. Thank you for the opportunity to provide testimony regarding House Bill 5373. I have submitted written testimony as well. My name is Rick Markello, and I'm the CEO of the Charter Oak Health Center. Charter Oak is a federally qualified health center in Hartford with 18 licensed locations providing over 80,000 healthcare visits annually. Approximately 2/3 of our patients are in Husky, the state's Medicaid program, so we serve about 11,000 Husky patients each year. We oppose Section 5 of this bill, which is designed to make it harder for health centers and other providers to obtain reasonable rates. Section 5 removes the provision of binding arbitration so that the Department of Social Services has arbitrary authority to disregard the rules of the Medicaid program. Our concern is that, as written, the bill takes away our options to control our financial well-being and forces health centers like Charter Oak to spend the money on lawyers and take the rate denial cases through the court system, which can be a lengthy and expensive process. As an example, we offer one of the few urgent care walk-in clinics in the city of Hartford, which is accessible by any patient with or without the ability to pay for services. We did this to combat the ever-present overcrowding at the other large hospitals in the city. I can tell you from experience, there is nothing worse than having a loved one who is sick and feeling like there is nowhere to go and no one who will help. Our services help relieve the overcrowded hospital emergency rooms where someone with less than a life-threatening emergency could wait hours to be seen. To have a legitimate urgent care walk-in center, you should have radiology or x-ray services. Medicaid does not allow health centers to bill for the extra radiology services because they are theoretically already built into the cost of the visit. Emphasis on theoretically. How does a health center get the cost built into the rate? They file what is called a change in scope. The DSS requires health centers to file a change in scope within 30 days of starting the service, along with the cost documentation to justify the rate adjustment. Well, it takes several months of operation to build up a service and document the cost. So DSS denies the change in scope request that is submitted in 30 days because it does not have the required cost documentation. Then when our health center submits the cost documentation several months later, the DSS denies the rate adjustment request because the cost documentation was not submitted within 30 days. This catch-22 is a gross abuse of the process. So what other options does a health center have to get a fair hearing and justice? Either sue and go to court, a lengthy and expensive process, or request binding arbitration. I'm gravely concerned that we are here today discussing the option of eliminating binding arbitration. Connecticut has the lowest Medicaid reimbursement rates in New England. I find it disappointing that given those low rates, that we would take away another potential option for health centers like Charter Oak to improve their finances by allowing fair and reasonable rate increases through arbitration. If the state wants to participate in the Medicaid program, it needs to be prepared to follow the rules and adequately fund health centers. I strongly urge your opposition to Section 5 of House Bill 5373. And just as an anecdote, we submitted a change in scope request over 6 months ago and have yet to hear a reply, yes or no. Thank you.
Thank you, Mr. Markello, for your testimony and for being here today. Next, we will hear from Rebecca David.
Good afternoon. Thank you for the opportunity to testify in support of SB 315, an act implementing the Certified Community Behavioral Health Model in the Medicaid program. My name is Rebecca Farley David. I am with the National Council for Mental Wellbeing. The National Council is the national voice for community mental health and substance use services across the nation. We advocate for policies to ensure equitable access to high-quality services and build the capacity of mental health and substance use treatment organizations. The National Council has worked side by side with states and clinics implementing the CCBHC model since the original Medicaid demonstration program was enacted in 2014. We have seen time and again how this model has made a difference to communities across the nation. The CCBHC model reflects best practices in mental health and substance use care. It prioritizes evidence-based practices. It requires that clinics be able to offer quick access to services. It ensures that people can access a comprehensive continuum of care to meet their full needs. It establishes expectations for partnerships and care coordination across the health and human services sectors, and it emphasizes reaching individuals outside the four walls of the clinic to make it easier for them to get the support they need when they need it. When CCBHCs are implemented in Medicaid, this is all supported by a payment model that reflects their reasonable costs of expanding services and engaging new populations in care. And we have seen transformative early results from this demonstration. To share just a sampling, CCBHCs in the Medicaid demonstration report that the number of clients they serve has increased by an average of 30%. The newly served clients are primarily individuals who did not previously have a regular source of outpatient behavioral health care, which is an indication of this model's ability to fill gaps in unmet need for care. These access expansions are due in part to the workforce expansions the model enables. CCBHCs in the Medicaid demonstration have hired an average of 44 new staff per clinic. They report less turnover and lower vacancy rates since becoming a CCBHC. This is possible, as you heard from others, because their Medicaid payment model is expressly designed to support the real costs of bringing on new staff to meet their community's needs. States have reported substantial reductions in hospitalizations and emergency department visits among CCBHC's clients, which is leading to cost offsets. Oregon reported a 22% reduction in inpatient utilization among CCBHC clients as of 2023. In Missouri, emergency department encounters have dropped by 36% and hospital encounters have dropped by 35% since 2017. New York reported after their first year of CCBHC implementation that the model had resulted in a 27% decrease in monthly behavioral health inpatient costs and a 26% reduction in monthly emergency department costs. This model demonstrates that when financial incentives are aligned to the most effective clinical model, you get results that would not otherwise have been possible. As one CCBHC executive put it to me in the early days of the demonstration, now that we've seen what service delivery can be like, we could never go back. The CCBHC Medicaid demonstration is being phased in nationwide over the coming years. Connecticut's next chance to join the demonstration will come in 2026. We hope that your great state will seize this opportunity to transform care delivery and improve lives. Thank you.
Thank you, Ms. David. Just a couple of questions. So we've heard from providers today who are certified as CCBHs, but can you just explain how they're currently receiving funding versus under the CCBH model versus how they then would if we were to pass this legislation?
Yes, absolutely. There's two pathways currently for implementing the CCBHC model. In Connecticut, the clinics you've heard from today are recipients of SAMHSA CCBHC expansion grants. Those grants are time limited. They provide $4 million of funding over 4 years, and they allow those organizations to start up or to continue and expand their operations as a CCBHC. The problem with the grant funding is that it is time limited and that it is capped. It can't flex to accommodate increases in demand. It isn't sustainable beyond the end of the grant period. Although some grantees have managed to win repeat grants, that is by no means a guarantee and not something that you can base long-term capacity building on. The other option for implementing CCBHCs is through state Medicaid programs, with the most desirable option, I believe, being the CCBHC Medicaid demonstration. Under the demonstration, the state itself chooses to implement CCBHCs as part of Medicaid, and the state will certify the CCBHC or the CCBHCs. The state will confirm that they're in compliance with all of the requirements of the program. And then those organizations that receive that state certification would qualify for a Medicaid prospective payment rate that supports their cost of expanding services, reaching new populations, and doing all of the activities of a CCBHC. Under the demonstration, states receive an enhanced federal matching rate for all the services provided to Medicaid beneficiaries through a CCBHC.
Thank you so much. That's very helpful information. Don't see any hands, so thank you so much for being here today.
Thank you so much.
Next, we'll hear from Mark Maselli. Is Mark with us? No? Okay. Jordan Fairchild.
Good afternoon, Representative Gilchrist and members of the Human Services Committee. My name is Jordan Fairchild. I am the Executive Director of Keep the Promise Coalition, a grassroots coalition of people with lived experience of mental distress, trauma, and psychiatric system involvement. Keep the Promise Coalition builds community power as a means of promoting human rights, self-determination, community integration, and racial and social justice in Connecticut's mental health system. I'm here today to testify in opposition to the sections of HB 5053, which propose cuts to Husky A and C. So regarding Husky C, most of you are familiar that last session, the committee and the legislature wisely passed legislation to raise the income limits to 105% of the federal poverty level after the unearned income disregard. This equals an effective 147% of the FPL by October of this year. up from 97% of the federal poverty level, which was significantly and arbitrarily lower than the income limit for folks who are not elderly and not disabled on the Husky D program. When these changes go into effect, this will end the discrimination in income eligibility against people with disabilities and older adults in need of Medicaid covered services in our state. However, we are, of course, greatly concerned by the fact that this bill proposes to take away and cut back on those income limit increases, including also cuts for the Husky A program for caretaker relatives. When I was sort of describing the work that we do, one of our really important focus areas is community integration. And it's really important to consider that even though, yes, folks getting kicked off of these programs who would no longer be eligible because of these cuts can get some sort of coverage in private markets, they won't have equivalent coverage to the benefits that are offered through, for example, Community First Choice to Medicaid recipients, PCA services, other things that are necessary to keep people in the community in the most integrated setting possible and out of more expensive institutional settings. This is really a concern for community integration and people's right to receive those services where they are most comfortable with their community. Recovery from psychiatric system involvement, mental distress is really hindered by not being able to receive those services in the community setting with your community support system around you. So again, we urge you to reject these cuts and protect the ability of these folks to maintain coverage on Medicaid to stay in the community. Thank you for the opportunity to testify today.
Thank you. Thank you so much for being here and for your testimony. Next, we will hear from Sheldon Tubman.
Thank you. Good afternoon, Representative Gilchrist, members of the committee. My name is Sheldon Tubman. I'm the litigation attorney at Disability Rights Connecticut. We represent a full range of people with disabilities in the state. So I'm here to testify concerning also the cuts to Husky A and C. With regard to the cuts to Husky C, I wasn't here, but I understand that earlier some legislators said, well, we just can't afford to end the discrimination. And I just want to point out that we have a constitutional clause in this state, in our state constitution, that prohibits discrimination on the basis of religion, race, color, ancestry, national origin, sex, or physical or mental disability. Just imagine for one moment if we had lower income limits for people who are Black than for people who are white, and said, well, we just can't afford to increase to match the people that have the white people with their higher income limit. Obviously, nobody would find that acceptable. Why is it acceptable to suggest that people with disabilities can have lower income limits than people who are able-bodied? And I should point out that the increase that the legislature wisely adopted last year does go a little higher than Husky D, but the cost for people with disabilities, there's no question. One study found a significant increase of about 28% more cost overall for households that have somebody with a disability in them than other households. The other thing, of course, is Husky A. And you've already heard Jordan just talked about how the services are not the same on the exchange and covered Connecticut versus Medicaid. In my written testimony, I explained many of the differences, including the fact that there are special federal rules that protect access to services, broad amount, duration, scope rules, prohibitions on exclusive lists, et cetera, that apply only in Medicaid and not on the exchange. The other thing that was not in my written testimony is that there's a very different definition of medical necessity in Medicaid versus commercial insurance, including on the exchange. And that definition, the Medicaid definition, which is 17B-259B of the statutes, has words that don't appear in the commercial definition of medical necessity, such as that the services must include things to rehabilitate or ameliorate an individual's medical condition. And it also includes special language that also covered our services to attain or maintain the individual's achievable health and independent functioning. So those are special rules you don't get in commercial insurance or in the exchange. And I pointed out in my written testimony that there's also the fact that commercial insurance is run for profit and they're capitated and they deny claims, to increase profits, which is not the case in Medicaid. But in adding that to the fact that there are actually different standards, you can see there are a lot of services that are going to be different that you're not going to get on the exchange. But I also think, finally, it's important to recognize that there's a significant group of people who will not go to the exchange, who will not go to Covered Connecticut with any subsidies. And that is anybody who's on Husky A over 138% of poverty, who is 65 or older, there's plenty of grandparents in Husky A, or who is disabled and on Medicare. These individuals are prohibited from receiving any federal subsidies and therefore any Covered Connecticut subsidies, and therefore the exchange is completely unaffordable to them. They will receive no compensation. They will receive no services. And one final point, which is that I noticed that the Deputy Commissioner of DSS said, well, they can go to Medicare Savings Program. The Medicare Savings Program doesn't help you with services not covered under Medicare. It just covers cost sharing that for services that are covered by Medicare. It won't help you with medical transportation, dental, eyeglasses, home care, et cetera, et cetera, et cetera. So those people, and it's way more than 22.
Thank you, Sheldon. Your
will not
time
have
has
access.
expired. Can you summarize?
Sure. I was just about done. Thank you very much. Happy to answer any questions.
Thank you so much. Representative Johnson.
Thank you so much, Madam Chair, and thank you for your testimony, Sheldon. Could you just talk a little bit about how the impact of the Medicare Advantage plan is having on people who are utilizing the Medicare Savings Program, but nevertheless, they're also being sold a Medicare Advantage plan because of the dental, hearing, and visual things that they can get through a Medicare Advantage plan. Could you tell us a little bit about that?
Well, that's a whole nother complicated problem, but the short version of it is that Medicare in general does not cover those extra services you mentioned. And the Medicare Advantage plans market that you will be able to get those extra services if you sign up with their plan, their Medicare Advantage plan versus traditional Medicare, which is true for people who don't have Medicaid. People who have Medicaid already have those extras fully. And when they advertise, they say you can get, maybe $1,000 in dental, $1,500 in dental, and maybe 15 or 18 and medical transportation trips. People on Medicaid already have all of that without limitation. So the advertising is really misrepresentative. But for people who don't have Medicaid, it might appear to be extras, but the reality is these services are limited. They're hard to get. And the Medicare Savings Program does address people's needs such that they don't need a Medicare Advantage plan, except for the services that you cannot get at all because you're not on Medicaid if you're not. Does that answer your question or help?
Well, it helps a little bit, but just to follow up quickly, that sometimes people get the Medicare Savings Plan, but say, oh, I can get dental, so I'm going to sign up with the Advantage Plan too. Do you have anything to add to that?
If they're not in Medicaid and they're on the Medicare Savings Program, if they choose a Medicare Advantage plan that does cover those limited extra services, then those are extra. I can't deny that those are extra services they wouldn't otherwise have.
Thank you so much. Thank you for your testimony. Thank you, Madam Chair.
Thank you, Representative. Thank you, Sheldon. So good to see you. Thanks for your testimony today.
Good to be here. Thank you.
We're going to Marianne Langdon, followed by Heather Gates.
Hello, chairs, Gilchrist, Lesser, and members of Human Services Committee. My name is Mary Ann Langdon, and Jill Bentavango, who is my personal assistant, will be reading my statement that I've written for today's meeting. I am very opposed to the proposed Medicaid cuts, especially to Husky C. Does it make sense to massively cut Medicaid specifically for low-income, older adults and disabled people by taking away the scheduled increase in income eligibility for Husky C to match and slightly exceed Husky D eligibility scheduled for 10/1/24 and reinstate the income eligibility discrimination against older adults and people with disabilities in our Medicaid program? No, Cutting the essential Medicaid program will exacerbate health disparities. The governor's proposed cuts will, 1, terminate many people from coverage at income levels disproportionately represented by Black and Brown people. 2, increase medical debt, which the governor cares about because of the impact on Black and Brown people and is seeking to reduce by making many more people incur large medical debt, up to $511 a month or more, to qualify for Medicaid under Husky C, or as a result of newly paying on credit for things like dental services because they have lost their Husky A coverage with no substitute. I am on Husky C, and it is the only way that I can obtain my durable medical equipment. My power wheelchair costs $60,000, and power wheelchairs have a lifetime of 7 to 10 years. Please do not cut Husky C under the Medicaid program. Thank you.
Thank you so much for being here today and for your testimony. All right, we'll go to Heather Gates.
Good afternoon, Representative Gilchrist and members of the Human Service Committee. I'm Heather Gates, and I'm the president and CEO of CHR. We provide mental health, substance use, supported housing, foster care, and we serve 25,000 children, families, and adults every year throughout the state of Connecticut. We also operate 2 certified community behavioral health clinics, one which is in central Connecticut and one in northeast Connecticut. I'm proud to say we were the very first CCBHC in Connecticut meeting the certification criteria set forth by SAMHSA and funded by SAMHSA, not by Medicaid. So I thank you for the opportunity to testify on SB 315 to hopefully bring Medicaid funding to the state for the CCBHC model, which is a system of care for the full age span. You've heard some description of the model and all the elements. I've also included in my testimony pretty extensive description. I'm not going to go through that. I also attached slides about our successes to date, which I would really urge you to take a look at because it's pretty incredible what we've been able to do with this funding. CHR applied for funding to really augment services funded by DMIS, DCF, and DSS, given the demand for services and the lack of increased funding from Connecticut. You've all heard from me about the fact that Connecticut is not keeping up with the cost of care, with inflation, and the stagnant funding that we have experienced. And now we also have the DSS rate study, which shows the very significant 50% difference in Medicaid rates for outpatient for behavioral health compared to other states. So those were all a factor for us in applying for this funding because we saw the need and we knew it needed to be addressed. We also experienced reductions from our state agencies. Just yesterday, we were informed by DMIS that one of our core services as an LMHA is being reduced by 12.5%, almost $300,000, based on an effort they're going through to, quote, right-size their system. So we need a more stable funding source for our services. Behavioral health in Connecticut, in my opinion, is in crisis given the way things are funded now. So the time to implement is now, and it's not to replace what exists, but rather to build on the successes to date for children and families as well as the adults that we are serving. And it's not an either or situation. It's not either do CCBHC or keep things the way they are. It's really how do you enhance what is there currently. I'm going to quickly go through some of the things that we've accomplished with our newest CCBHC in the Northeast. We opened a clinic for children in Killingly in the schools in order to serve youth in that area, which has been critical. We've added peer supports and engagement specialists to help people access housing and address food insecurity and benefits. We've added recovery support specialists in Danielson to help with greater access for MAT and opiate dependence. We've increased by 27% access to primary care in our on-site clinic and including ambulatory withdrawal management. We have also been using engagement specialists, and the Connect to Care and engagement is 30% better when an engagement specialist is involved than when one is not involved in outpatient.
Ms. Gates, your time has expired. Can you please summarize?
Yep. I will summarize by saying I think the state cannot afford to turn its back on this opportunity with Medicaid, and it owes the citizens of Connecticut the services that would be provided with this funding model and the system of care that it would create.
Thank you so much. And we'll be sure to go back and look at your testimony, which includes all that important data. So thank you for being here.
Thank you. Thanks very much.
Next, we'll hear from Dan Karp.
Good afternoon, Chairman, Chair people, Gilchrist and Lesser. I'm here to testify on House Bill 5366, which is an act concerning covenants not to compete in the home care industry. My name is Dan Karp. I'm operations manager for Care at Home in London, Connecticut. In 2010, my wife Suzanne started Care at Home, and we now employ more than 90 people. Care at Home provides individual non-medical assistance and support to seniors in order to improve the quality of life of persons who wish to remain at home but require additional care and support. Our caregivers provide hourly and respite care, overnight and live-in care, depending on our clients' individual needs. Care at Home has earned an A+ rating from the Home Care Standards Bureau, is a member of the Home Care Association of America, and is a certified trusted provider of Home Care Pulse. I wanted to provide comments on House Bill 5366, which I generally support. The bill is an incremental step in the right direction towards restoring the proper balance in the relationship between home care agencies, caregivers, and clients. However, the bill lacks any enforcement measure, and I think there are other provisions in the law concerning no hire clauses may be the proper vehicle to address the relationship, in addition to the non-compete issue. In 2022, no hire clauses were summarily prohibited in home care contracts. These were clauses that were customarily used in agreements privately negotiated between clients and agencies that allowed owners to protect their most valuable assets. By banning these clauses, caregivers and clients were placed at risk of, and state revenue was undermined. I hope the legislature will see fit to restore the ability of home care agencies to include no hire clauses in agreements with clients. I also wanted to say that in reference to this non-compete clause for non-medical home care companies, which is enforced by a Department of Consumer Protection, is not fully thought through. I'm not against giving employees the right to work for other employers, as the DSS commissioner said that her view on this was that they should have the right to work for other employers. I agree with that. But there is a problem with the non-compete provision in the current statute for non-medical home care companies. When an employee who is supervised and trained by a home care agency decides to approach a client directly to hire them directly, there is no classification requirement for this person to be an employee and file the appropriate paperwork. There's no state labor laws such as overtime, income tax withholding, Medicare and Social Security deductions, liability and workers' compensation, insurance, sick time, PTO, vacation, dental, vision, holiday pay, all the benefits that we currently provide. Instead, I think, and so it's really to the disadvantage of that particular employee and the client to create a situation like this. I think it's best to leave the question of non-compete rules to the state judicial system rather than legislating for specific types of businesses who can have non-compete and who cannot. But thank you for listening. If you have any questions, I'd be glad to answer those.
Thank you, Mr. Karp. Very helpful testimony. I don't see any hands. Thank you for your time today.
Thank you.
Next, Marlene Ciccarella.
Hi, good afternoon, Representative Gilchrist and members of the Human Services Committee. Thank you for this opportunity to speak on behalf of House Bill 5366, an act for concerning covenants not to compete in the home care industry. My name is Marlene Ciccarella. I'm a non-medical agency owner serving Medicaid clients in New Haven County, as well as chair for the Connecticut chapter for the Home Care Association of America. HCAOA Connecticut supports House Bill 5366 and respectfully requests that the Human Services Committee approve the bill. The bill allows homemaker companion agencies to have, as once was customary in the industry and many industries, time-limited narrow agreements with their employees they have interviewed, trained, and placed in clients' homes that prevent private contracts with agency clients that owners have developed and cultivated. As a non-medical agency owner, I can speak to the amount of time and expense invested into our caregivers and office administration to ensure our clients receive quality services. Home care agencies shoulder that expense and responsibility that is undermined by the existing policy. Up until 2019, when the legislature adopted a ban on the provisions in state budget, home care agencies were allowed to use standard lawful non-compete or non-solicitation agreements in the ordinary course of business, which has been used for years. The main purpose of the clause is to protect the business that many agencies in Connecticut have worked hard to develop, and the client from becoming sometimes unknowingly the employer. There's many valid reasons why home care agencies should be permitted to use non-solicitation agreements. They're vital to operations, assuring companies have skilled employees available to answer the needs of clients, assure that caregivers do not retain a client in whom an owner has invested significant time and resources, trained and placed for a reasonable limited period of time. Without these limited agreements, it is difficult to assure the quality of services provided, and they are an effective tool for protecting agencies from losing private pay clients to under-the-table competitors. House Bill 5366 carefully balances the competing interests at stake without disrupting home care agency owners' ability to own and operate their businesses, provide essential in-home services, allow caregivers to earn a living, and enable senior consumers to continue to have access to uninterrupted care. I would like to thank the committee, its leadership, and the group of lawmakers who have worked for the last several years on the policy and for introducing this important bill that would restore balance to the employer-employee relationship in the home care industry, protect caregivers and consumers, and preserve state revenue. Thank you again, and I ask you for support and approval of this bill.
Thank you so much for your testimony. Yep, Rep. Cook has a question.
Sure.
Thank you, Madam Chairman. Just a really quick question. So in the bill, it states 6 months. Do you find that to be a long amount of time? Or do you think that's not long enough? I'm just curious because I find that 6 months is a lengthy amount of time.
I think it's reasonable. Some agencies do less. They may say 3 months, 5 months, but I think 6 months is reasonable.
So you're looking for consistent, flat 6 months across the board with no exceptions to any conversation?
That's a really good question. I would have to get back to you on that, but I would think that should be the standard.
Yeah, I would like to hear your thoughts on that because I think that a lot can happen in 6 months. And, you know, if somebody has a medical situation and they have to quit work and the only thing that they can do is find work privately for a little while, then they need to have the ability to make money. And I think that if we prohibit them from whatever that might look like, we need to be cautious as to a blanket statement on 6 months. I think we need to have a little bit of flexibility. So I'd be curious as your thoughts.
Okay, so it doesn't limit them from finding employment if a client goes into the hospital or passes away or whatever the situation may be. All it does is limit the staff for working directly for the client that is contracted with the agency.
No, I understand what it does.
Okay.
All right, great. Thank you, Representative. Thank you again, Marlene, for being here today in your testimony.
Thank you. I appreciate your time. Thank you.
Next, we'll go to Diane Manning.
Good afternoon. I'm Diane Manning, President and CEO of United Services, which is the local mental health authority and certified community behavioral health center in the Northeast. We provide professional behavioral health treatment and support services to more than 500 individuals and their families and communities each year. We were funded for the CCBHC through a competitive SAMHSA process starting in October 2022 for federal fiscal year 23 and successfully received our certification in September of 2023. So thank you for the opportunity to testify in support of Senate Bill 315. Certified Community Behavioral Health Centers, CCBHCs, are a proven model of care that provide comprehensive behavioral health services and substance use treatments, including crisis care, regardless of an individual's ability to pay for those services. Once a clinic is designated a CCBHC, they and their partners are required to provide comprehensive behavioral health services across the lifespan, with an emphasis on the provision of 24-hour crisis care, evidence-based practices, care coordination with local primary care and hospital partners, and integration with physical health care. While we provide services for Northeastern Connecticut through our contracts, mostly with DEMAS and DCF, and while we are Medicaid providers and participate in Medicare and most other commercial payer plans, each of those sources, especially the grant funding, has target populations that make many people ineligible for the very services that will support their recovery from mental health and substance use disorders. CCBHC allows us to provide whole person care and requires us to provide care coordination for everyone we serve who needs and wants it. This means careful attention to transitions between levels of care and care coordination with the other medical and social services providers who might be working with that individual. CCBHCs must meet stringent standards to get and maintain certification. We meet those more than 100 pages of requirements and constantly work to design systems that meet the needs of the people we serve. We were part of planning for Connecticut to join the original early demonstration states, but that effort was abandoned in 2014. So far, Connecticut has declined several additional opportunities to apply for the program. The behavioral health needs of the state are growing, and demand for our services has increased dramatically, especially over the last few years. It is frequently difficult to get access to needed services because of waiting lists. States that have implemented this model have seen dramatic increases in access to services for people battling serious mental health and addiction needs. In the last year, we have already seen people served through our CCBHC care coordinators who have decreased hospital visits for minor issues because they've been successfully connected to primary care. We've identified housing for others, helped people return to work and community activities, and generally seen dramatic shifts in the use of inappropriate levels of care with the people who have agreed to participate. We anticipate even more successes as word of the availability of the service gets out in the community. Lastly, the funding mechanism for CCBHCs, a prospective payment system that incentivizes providers to serve those most in need, would give CCBHCs and their partners the opportunity to better plan for and balance their budgets while increasing access to care. The CCBHC funding system allows use of the right services at the right time and development of the models to meet local need, which will save the larger system significant cost. Thank you for the opportunity to testify in support of SB 315.
Thank you, Ms. Manning, for your testimony and for being here today. All right, Ben Shaken. Oh, you have an entourage. Look at that.
I brought an entourage. I'm not as good as Tom Burr. Good afternoon, Madam Chair, members of the committee. I'm Ben Shaken. I'm the Director of Government Relations at the Connecticut Community Nonprofit Alliance. We're the statewide association of community nonprofits, including Connecticut's community-based behavioral health providers. I am joined by my colleague, Monica Nugent, the newest member of our team, in part to introduce to you, and also because she is going to be specializing in working with our adult behavioral health providers. We're here to support Senate Bill 315. I want to repeat things that you've heard from other folks. I just want to highlight that since 2014, when these were enacted into federal law, now 28 states have implemented or are in the process of implementing these Medicaid demonstration projects. Across the country, more than 500 certified community behavioral health clinics are serving over 2 million people. And we have an opportunity in Connecticut to do something transformative with this bill if we decide to participate. Where they have been implemented earlier on in the process, we have some amazing data, much of which is appended to my testimony. I just want to highlight some of it. The first thing that I will talk about is access. You heard from Rebecca David earlier about some of the broader statistics in New York. close to us. Number of Medicaid clients served by these programs increased by 21% in just the first year of the program. Nearly a quarter of these folks had not received behavioral health services in the prior 3 years. And in Nevada, a 250% growth in the number of clients served through the CCBHC demonstration project, which is really, really incredible. Monica is going to talk a little bit about the other reason that we think you should do this.
Yeah, so in addition, CCBHCs are continuing to save states money, even though they have an increased Medicaid investment in behavioral health. So as Ben mentioned, our neighbor state in New York has implemented the system. And so in New York, a reported 54%, New York saw a 54% decrease in the number of CCBHC clients using inpatient care, which directly translated to about a 27% decrease in monthly cost. Additionally, New York reported a 46% decrease in the number of clients using emergency rooms for care. And so that decrease in emergency room care led to a 26% reduction in monthly costs. Finally, the state saw a 61% decrease in the number of clients using general hospital inpatient services and a 54% decrease in all case readmissions for care.
So we think Connecticut is well positioned to do this. You've heard from many of the direct grantees, which tells us that if Connecticut implemented this model, there would be providers who would be ready and willing to participate. As I think Diane Manning mentioned just before us, Connecticut was actually one of the original demonstration planning states. Back in 2015, we received the planning grant. At the time, after some study, the state decided not to pursue the opportunity. As Diane said, there have been a number every couple of years. Essentially, the federal government has expanded this program, and we've had a number of opportunities to participate. The last time was 2022. We declined that year. There is an opportunity this year to apply for another planning grant, which would, as Rebecca David said, allow us to apply for a demonstration in 2026. If you look at my written testimony, you will see appended to it, this is my summary, both a large study of state impact, but before that, a little 2-page fact sheet from the state of Missouri, just showing some absolutely remarkable transformative results there. We have an opportunity to be able to trumpet these results here in Connecticut if we implement this model, and we hope that you'll support the bill. Thank you.
Great. Thank you both so much. Truly all day, but your testimony has been very helpful, and we'll certainly go back and look at that additional research. Don't see any hands. Thank you for your time today. Next is Lynn Ritchie with us? Oh, it's the online and in person's a lot. Okay.
Good afternoon, Madam Chair, members of the committee. Thank you for allowing me to testify today. My name is Lynn Ritchie, and I'm President and CEO of Hospital for Special Care. And other than Rep. Gilchrist, I don't think that anybody here has been out to the hospital. So I thought it might be helpful for me just to frame who we are, particularly in light of the discussion this morning with the commissioner from DSS. So Hospital for Special Care is a chronic disease hospital. So we're not a nursing home by far. We are also not an acute care hospital. And really the differentiator there is we don't have an ER, we don't have an OR. We don't deliver babies, but we do a lot of, I think, really amazing things. We are unique in respect to the continuum of care that we provide. We provide care to babies through adulthood. So very unique services. Of interest, and I'm here to first thank you for introducing the bill 5372, but also here obviously to speak in support of it. Hospital for Special Care runs 82% Medicaid for our patients throughout those populations that we serve. Many of the individuals that we serve, there is not another place for them to go. About half of our patients are chronic in nature, so we do have some acute programs that are much more like the other chronic disease hospital in Connecticut that are more rehab focused. That really is not the focus of my conversation today. It's around those individuals who I can think of. We have 8 patients out today in the acute care hospital. So this is about bed hold we're talking. So what we have, we run 95% occupancy. There's a great demand for our services. We get calls regularly from acute care hospitals and others across the state who are trying to get access to our care. So today, our census is 225 out of our 236 beds. That does not include the 8 Medicaid patients who are out in acute care right now, waiting to come back. We are holding those beds. We do that because in many cases, this is our patient's home. They've been there, I can think of 3 cases today, one of which is a baby that has only been with us a couple of months, but will have no place to go if we were to give up that bed. We're the only place for children who need the complex care that we provide. We have an adult out who has been with us for 26 years, came to us 2 years old with a spinal cord injury. Again, the acute care hospitals would be quite upset with us if we were to tell them that after 26 years, we're giving up that bed and admitting somebody else to that bed. And the stories go on. I think you understand the point I'm making. But in the last 9 months alone, we had 783 days of care that were, because we held that bed, we were not able to bill for those services. That resulted in a significant loss of revenue for a hospital that's 82% Medicaid. So I thank you for first initiating this bill and hope that you will support it. Thank you very much.
Thank you so much. And truly for having me out and educating me. If you don't, that's totally fine, but do you know if other states, or I would assume you reach out and connect with, I want to get the term right. Hold on. Don't let me, the chronic disease hospitals, in other states, do they allow for a bed hold? Do you know?
I don't know.
Okay.
I actually sit on the national board for our level of care, which for CMS is considered a long-term acute care hospital. That's the terminology that they use. It is quite unusual to have patients. We're really blessed in Connecticut to have the support for individuals with the kind of complex care that we provide to be able to stay in that type of setting. That is not typical across the country, I would say. There are few states that have that level of support.
Okay, thank you. And I was just asking because this morning with the commissioner, when we were talking about the technical term, it seems is bed hold.
Right.
Just wondering if other states had already maybe done a waiver but we can certainly look into that. Yes, Representative Hughes.
Thank you. And thank you for coming to testify. Very specifically, I wanted to verify you are a nonprofit, right?
Absolutely, yes.
And are you looking to align the bed reservation, if you call it that, with the way nursing homes do?
That's correct. So we are, again, we are not for profit. We are independent. We're not aligned with any system. We're standalone since 1941. The state considers us as part of long-term care for a lot of regulatory reasons. For example, during COVID, all of the long-term care rules and regs apply to our level of care, but in this case specifically, the language in the bed hold language for nursing homes excludes chronic disease hospitals. So yes, we're looking to align with the nursing.
So basically, you're just asking for HB 5372 to update to the way Medicaid is reimbursed currently for long-term
for the
care.
Skilled nursing
For the skilled nursing, exactly, which obviously you're skilled nursing and above. Yes. So yeah, if we kind of frame it more along that, we're already doing that in these other settings. So thank you.
Thank you. Very helpful. Yep, Rep Cook.
I really have no question. I do have a statement though, and I just want to, I've been to your facility and I think that what you do there is just beyond remarkable. And the outcomes that you all have surpass, I think, often the imagination or what a family might think that their loved one would be able to outcome or achieve. So just thank you to your staff and to everybody that is there that make the place a special place. So
thank you. I'm honored to hear that. I'll be very happy to take that back to them.
Thank you, Representative. Senator Seminara.
I too just wanted to mention that I have been to your place and my daughter has been a patient there.
Oh.
So that I do think the care that you provide is top notch. I cannot say more positive things about your facility. So let's see what we can do to help you with this.
Thank you. I'm very grateful. Thank you for that.
Thank you very much.
Sure.
All right. Have a great afternoon. Oh, let me check Zoom. Okay, good. Next is Christina Emery.
Good afternoon, Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Cook, and Representative Case online, and distinguished members of the Human Services Committee. My name is Christina Emery, Executive Director of Brooker Memorial. We're a nonprofit agency in Torrington dedicated to the health and wellness of children. And thank you for allowing testimony on HB 5053. As a designated safety net provider, we have been serving low-income children throughout Northwest Connecticut since 1994 and are committed to equitable access to oral health care services for all. Brooker Memorial understands that children affected by tooth decay are at risk for pain, nutritional problems, teeth loss, difficulties with speech, and poor long-term oral health and other chronic diseases. Last year, we provided more than 8,700 visits in our dental center in Torrington and at 10 public schools located throughout Litchfield County. 85% of these patients are either receiving Husky or are uninsured, making us the largest provider of dental care for low-income children in Northwest Connecticut. We receive no additional supplemental payments for caring for a predominantly Medicaid population. Last year, our dental program filed 3,900 Husky claims for an average reimbursement rate of $125 per claim, compared with 149 PPS rate paid to the local federally qualified healthcare center. And as we heard today, both of these rates are well below our actual costs and well below private insurance reimbursement rates for the same services. The Brooker Memorial Pediatric Dental Clinic had a net loss over $208,000 last fiscal year due to these low Husky reimbursement rates, charity care for the uninsured, and increasing expenses. We know there's more children in Litchfield County that need our services, and we want to reach these children. But the current financial outlook is threatening our ability to provide care for at-risk populations in the future. I urge you to consider increasing the pediatric dental rate for community safety net providers to ensure all children, especially those most at risk for poor oral health, have equitable access to critical services. Thank you for your time and consideration.
Thank you for being here today. Senator Seminara, followed by Representative Cook.
Hi, Christina. Good to see you.
Thank you.
I think it's important for you to highlight for people who may not know, why are you not eligible for supplements for Medicaid?
Yes, thank you for the question. Brooker Memorial is a unique provider, a unique safety net provider. We are not a federally qualified healthcare center or a university-based system or a dental school. So we rely on Husky only, and then our private fundraising efforts. We receive no supplemental payments.
And you have testified earlier that as of last year, $208,000 net loss. Is that correct?
Yes, in that dental program, yes.
Okay. How are you with providers? Meaning, are your providers up to snuff? Do you have enough providers?
We would like to add another pediatric dental provider. That comes at a tremendous cost. We know that, as I said, there's more children in Litchfield County that have not had a dental visit, and we want to reach those children. We also provide dental hygiene services in Torrington Public Schools and Region 1 Public Schools as well.
Okay. Are you at turning anybody away at this point?
Not now, but we're at the point where unless we can add a provider, we're going to have a wait list for services just because of capacity and increasing costs. The gap between our reimbursements and our costs is continuing to widen, and there's more data in my written testimony about that.
Okay. Thank you so much.
Thank you.
Thank you, Senator. Representative Cook.
Thank you, Madam Chairman. And Christine, thank you for being here. And again, congratulations on joining the Brooker Memorial family. What they do is absolutely incredible. So I would welcome you all to come down and visit us as well. What I would like to move a little, so as the good senator talked about the uniqueness of your program and how you do that. And then you just talked about the deficit, which we see regularly.
So that's not a one-time deficit, that's an annual, like we lose money every year at Brooker. Recognizing that you just came aboard, could you talk to what that would look like over the years as that continues to pile up?
Yes, we're trying to look at community needs. We're trying to assess what else we could do to, address the social indicators of health for children. And that gap is going to hinder our ability to expand services. We partner with another provider to provide pediatric OT, PT, and speech therapy. We provide infant care, child care, after school program for children. And we're looking at what else we can do to meet the needs of the community. But again, that growing deficit specifically in our dental clinic is really hindering our ability to do that.
And then with that also, as you talk about right now, you're not turning people away, but obviously with the limited amount of providers that you have, there is a wait for somebody to see a provider.
Yes.
Could you talk about that wait and what that time would looks like currently?
Yeah, there is a wait for our dentists. We have one full-time pediatric dentist. We have a few part-time dentists. We are trying to work with UConn Dental School to see if we can get another resident dentist on our staff to help address that need for services.
So are we talking a couple of weeks, a couple of months for somebody to get literally in a chair in front of a provider?
Yes, it takes at least a couple of weeks at the current time, but again, the demand is increasing. We're also seeing an increasing demand from our children residents that are Spanish speaking. So we need to add a provider that's bilingual as well. We see that as a real need right now.
Thank you. And Madam Chair, I think it warrants the conversation to say when she talks about the entire northwest corner, that's hundreds upon hundreds of miles that they are covering right now. So thank you. Thank you very much. Thanks,
Thank you.
Christine.
Thank you, Representative Cook. Senator Lesser.
Hi, I have a question I actually asked previously, but
Sure.
would love to drill down on this. I understand that you're not really getting those extra compensation methods that other types of organizations
Right.
get. Have you explored becoming an F2HC? What are the barriers to doing that? Because it seems that would solve a lot of the problems that you're
Yes,
experiencing.
and that's something that we're, certainly open to having a conversation and looking more into. There is a Torrington Community Health and Wellness Center. We actually collaborate with them. When they formed, they were in our building. We partnered with them to offer space. Right now, we have a good collaboration where they provide adult dental clinic services. We provide pediatrics. So, we certainly don't want to compete with them, but continue to collaborate. We also don't offer the full array of services right now. We don't have, behavioral health and primary medical care as well. So that would be something we would have to consider expanding.
Okay, thank you.
Thank you.
Thank you so much for being here today and for the work you do. Next up is Susan Lagarde.
Yes, good afternoon. Senator Lesser, Representative Gilchrist, members of the Human Services Committee. My name is Dr. Suzanne Lagarde. I am the CEO at Fairhaven Community Healthcare in Fairhaven, in New Haven, Connecticut. I am here to provide strong testimony in opposition to language in Bill 5373. Specifically, in Section 5, the proposal would remove the option of binding arbitration for appeals contested by agencies such as our health center. Stated simply, this attempt at legislative maneuvering is a thinly veiled effort to limit health centers the opportunity for due diligence when requesting a change to our Medicaid rates. Per federal law, FQHCs are paid based on a PPS or prospective system basis. This is a cost-based process protected by the Benefits Improvement and Protection Act, or BIPA, of 2001. Despite the clarity of federal law, Connecticut has a long history of denying legitimate requests for rate adjustments. As a result, health centers appealing arbitrary decisions by DSS need for there to be a fair process in place when such appeals are arbitrarily denied. Removal of the binding arbitration process will simply be another quiver in the state's armamentarium to deny rate adjustments that in fact are legally due the health centers based on federal law. Please allow me to share our story. Our health center at Fairhaven submitted a request for a rate adjustment in October 2016. Despite multiple legally appropriate reasons for approval, it was denied. We resubmitted a request in April 2019. Once again, it was rejected. We appealed that decision, and in June 2021, a two-day hearing adjudicated by an attorney employed by DSS took place. Once again, the majority of our request was denied, and approval of an increase in our rate of literally pennies on the dollar was agreed to. 5 years following our original request, armed with the conviction that our patients were being denied services due to errors in law by Connecticut DSS, we were faced with two options: bring the case to binding arbitration or proceed to Superior Court. The decision was very easy. We simply could not afford the cost of the Superior Court route. We opted for binding arbitration. In August 2022, we argued our case before 3 appointed judicial experts: a judge trial referee appointed by the Connecticut court system, a retired judge who we recruited and paid for, and an attorney recruited and paid for by the state. A unanimous decision was handed down in December 2022 and found, and I quote, "Fairhaven's substantial rights have been prejudiced because the DSS decision is in violation of statutory provisions affected by other error of law, characterized by abuse of discretion or clearly unwarranted exercise of discretion." Members of the Human Services Committee, the current proposal before you is a thinly veiled attempt to deny health centers the opportunity to challenge the state's repeated denials of rate increases, which are in fact appropriate based on federal law. I strongly urge you to reject this proposal. Thank you, and I have submitted written testimony. Thank you.
Thank you, Dr. Lagarde. I mean, 2016 to 2022 is just absurd. And so maybe we could address that process before changing arbitration, but I've been here all day. Does anyone have any questions? Senator Lesser.
Well, tell us how you really feel, Sue.
All I'm looking for is what is legally fair, what our federal statutes mandate, which in my opinion, and I studied this extensively, are being arbitrarily overlooked by Connecticut DSS.
So a few hours ago, I asked the commissioner about this, and because to my mind, we're moving backwards, right? The Medicaid rate, the first phase of the Medicaid rate study said that we need to take more of the decision-making out of the hands of the legislature, empower DSS to develop a rational rate setting mechanism across Medicaid. And yet doing away with this seems to, doing away with the binding arbitration seems likely to break one of the few systems that kind of sort of work sometimes. And so now she argued that this wasn't a step backwards because, we are still waiting for phase 2 of the study, but I'm assuming you don't agree with that.
With all due respect, and I do have respect for the DSS commissioner, we've been on this journey since 2016. The denials are arbitrary. The whole system is in a mess, in my opinion. There's no clear guidelines as to what is or is not acceptable to the state. We know what is required by federal law, but then there are these arbitrary decisions that you heard about earlier today, based on if this is not submitted within 60 days or within 30 days. And as you've also heard, as a result of all of this, we are by far the lowest paid community health centers in New England. In fact, if you look at the country as a whole, we are pulling up the bottom along with Alabama and Florida.
Not great. Well, we have legislation that might address that, so come back.
I will be back. As you once referred to me as a frequent flyer senator, and I continue to frequently fly. I will be back.
That was intended as a compliment. Thank you, Madam Chair.
Thank you, Senator, and thank you so much, Dr. Lagarde, for being with us today.
Thank you so much for taking the time. I appreciate it. Thank you.
Next, we'll hear from Jean Mills Aranja.
Thank you and good afternoon. My name is Jean Milzer, and I'm a volunteer attorney with Connecticut Legal Services, where I practiced elder law before my recent retirement. I also served on the governor's nursing home and assisted living oversight working group, which examined solutions to the crises that rose in these facilities during the COVID-19 pandemic. On behalf of Connecticut's legal aid programs and our low-income elderly clients, which include residents of nursing homes, I'm submitting testimony in support of Senate Bills 318, 310, and 311. However, based on the comments of the Commissioner of Social Services and the questions raised by Representative Cook, I'll just refer you to my written testimony, which was supporting the study of private equity ownership in nursing homes, and say that I think that Representative Cook makes a good point, as does the Commissioner, that perhaps we don't need this study, and that instead we should try to figure out a way to really address the problems of private equity firms. As I think most of us agree, overall private equity homes keep staffing low and provide poor care to residents while driving up costs and extracting high profits and resources during their limited ownership. They then sell quickly, leaving nursing homes in poorer condition than before. The solution to this was suggested by a national expert, Ernest Tosh, when he came to speak at the Capitol about a month or so ago. And his solution is legislation requiring private equity firms to submit consolidated financial reports, which are audited by a third-party CPA and made publicly available from the parent company to the bottom of the structure, and also disclosure of ownership all the way to the individual investors. It's only by getting this kind of transparency in finances and ownership that we'll be able to see where all the Medicaid dollars are really going and what they're really going for. And from that point, when we can really see where they're going, I think we'll be able to direct them much better towards actual care for the residents rather than profits for the private equity firms and their investors. There is apparently has been legislation passed in California to this effect, and I understand that the National Consumer Voice for Quality Long-Term Care is developing model legislation drafted with this in mind. So perhaps this is something that Connecticut could look to rather than a mere survey to show something that I think we all already know about the quality of care given through these private equity firms. I just also like to mention that I did want to testify on behalf of Senate Bill 310 about family caregivers, retroactive eligibility for Medicaid and treatment of after discovered assets, and 311, an act concerning the home care program, which has many excellent provisions to expand that program and provide care at home for people who want to stay at home and also save the state money. But as I said, I'll refer you to my written testimony for that. Thank you for the opportunity to speak before you today, and I'm happy to answer any questions. And thank you for your concern for nursing home and other elderly residents of the state.
Thank you, Jean. Thank you for being here and for your testimony. Representative Hughes.
Well, thank you, Jean. Yeah, I'm glad to see some folks from that oversight task force or council still in the trenches, as it were. Is your testimony that you would rather see retroactive than presumptive eligibility for Medicaid for the elderly home care program?
I think I'd like to see both.
Right. Okay. Is that in your testimony?
Yes, it is.
Both. Okay, great. Thanks. I just want to clarify that because we have a bill in aging that's all about presumptive, but not retroactive. Thank you.
Thank you. All right. Seeing no other hands. Thank you again, Jean, for your testimony today.
Thank you.
Is Stephanie Bourassa with us? Okay, then we are on to Jay Coley.
Good day. Co-chairs and committee members, thank you for allowing me to be here today. My name is Jay Kiley, and I have owned Synergy Home Care of Fairfield for the past 12 years. We are registered with the state as a homemaker companion agency and have been a long time Home Care Association of America member. We have assisted roughly 1,000 Connecticut families and trained hundreds of caregivers over the years. At present, we employ nearly 100 caregivers in the state who provide essential in-home services to seniors, individuals with disabilities, and veterans. We ensure quality care. We interview, check references, run background checks, complete motor vehicle checks, screen, employ, train, and supervise these caregivers, all of which costs money. Up until several years ago, we were allowed to protect our Connecticut businesses by setting rules where clients could not steal or poach caregivers, and caregivers could not steal or poach clients. For some reason, our vital industry was singled out, and this policy became illegal. I support House Bill 5366 and respectfully request that the Human Services Committee approve the bill. I wish to thank the committee, its leadership, and the bipartisan group of lawmakers that have worked on this policy that would start to restore the balance to the employer-employee relationship in the home care industry, protect caregivers and consumers, and preserve state revenue. To obtain clients, we hire marketers, pay for advertising, rent storefronts, and employ office staff to develop these clients. We pay income tax, unemployment tax, Social Security tax, provide workers' comp, among others, to safely put caregivers into people's homes. When an employee-client combination leaves a homemaker companion agency, you can bet none of these taxes or safeguards are paid or maintained. House Bill 5366 allows homemaker companion agencies to have, as once was customary in the industry, and I believe is still customary in most Connecticut industries, time-limited agreements with the employees that we have interviewed, trained, and placed in these clients' homes. Up until 2019, when the legislature adopted a ban on these provisions, we were able to do so, and we would like to be able to do so again. The ban has had unintended consequences, such as putting client safety at risk and undermining state revenue. Without these agreements, not only do the over 900 owners like me risk losing their business, but it puts unsupervised caregivers in a home where the client, sometimes unknowingly, becomes the employer of the caregiver, requiring items like paying quarterly taxes and purchasing insurance. There are many valid reasons why home care agencies should be permitted to use non-solicitation agreements, such as they are vital to operations. They assure that caregivers do not steal or poach a client in whom an owner has invested significant time, efforts, and resources. They are an effective tool for protecting
Mr.
agencies.
Foley, your time has expired. Can you summarize?
Yes, I wish to ask that you move forward and approve this act because it is better for the agencies, the caregivers, and the people that we serve.
Thank you very much. Any questions? All right, seeing none, thank you for being here today and your testimony.
Thank you.
And that, I believe, is our last speaker. And so that concludes our public hearing. Our next meeting is this Thursday for another public hearing starting at 11. All right. Thank you, everyone. Have a great afternoon.